Welcome everyone to effectively what is the second, I know it's the third, but the second public meeting of the Integrated Care Board for Cornwall and the Isles of Scilly. One of the things I should say is a huge amount of things have gone on. I just wanted to thank everyone for their enormous efforts, both within this room and all our colleagues and staff across the whole system. It's been a huge amount of work done by everybody, and just wanted to recognise that. And as we go through this, if I could just ask you to make sure that when you get to your sections, if you can work on the basis that the papers are taken as read, assuming everyone's done their homework, done their reading, and we'll actually get into some real discussions and I hope agreements as we go through it. So if I can just welcome a couple of colleagues. Adrian, you're standing in for Debbie. I am. Yeah, yes. Welcome from CFT.
Thank you. Thank you.
And can I also welcome Will, who's the Chief Executive of SWAST.
Thank you.
Thank you so much for taking your time out. And I think everybody else should know everybody. Yeah?
Yeah, we've got a member of the public here from North and East. Would you like to...
Yeah, thank you. Nice to meet you. Hello there.
Would you like to just introduce yourself to the board, if that's all right?
Thank you very much. I'm Joan Heaton. I'm the chair of CAP.
Okay, Joe, yes.
So, I'm a lay member North and East Cornwall ICA.
Okay, welcome. Thank you ever so much. Of course, we have some members of the public I can see on the call. Trudy, apologies. Who are the apologies, or we're
all here, John.
all here apart from the ones I've mentioned, which is excellent.
We've already got deputies for.
While I've got this little part of the section, if I can congratulate Joe, you've made a fantastic appointment. Emma Rouse, starting, I hope, next month with us?
12th.
The 12th.
12th she starts
with you
formally, and then she'll be attending boards going forward.
Lovely.
For her absence when she's on leave.
Thank you. And that'll be both for the ICB and the Integrated Care Partnership, I take.
Yes.
Lovely. Good appointment. Thank you so much for that. Okay, so that's that element. Just wanted to share with everyone, we are, for those who can't quite see where we're at, we're actually based in Bodmin today, and the idea is we're going to rotate our integrated care boards around the 3 integrated care areas. So just to alert to everyone who would like to run away at lunchtime here, we're going to do the following each time. As we happen to be in the North East integrated care area here today, I've asked Andy, who is overseeing that particular area as the Managing Director, to bring some of your colleagues from the integrated care area to meet the board members over lunch and have thoughts and share views. So we pick up local thoughts as best we can and hear it direct. And that theme will rotate as we go around. So next time we'll be in, I think it's Heartlands, down towards Redruth, and then we'll be back in the centre, and we'll rotate it around like that, just so everyone gets a sense that we'll be hearing about place as we go forward. Okay, declarations of interest. Let's move on. You've got the paper. Are there any issues that anyone would like to raise on declarations of interest? I used to joke and say, still interested? Yeah. Good. Good. No issues on that paper, so let's move on. So we've got 2 questions, as I understand it, from the public. So, Rachel, could I ask you to be clear on what the questions were and the answers that we're giving? Thank you.
Of course. Thank you, Chair. And I want to thank Nigel Mawson for his questions that are going to help us shine a spotlight on the theme of virtual wards today, which, as many of you will know, is a key part of our prevention and admission avoidance, and also supporting people to be home quicker from hospital. So I'm going to read Nigel's question and the answer. These will be made public on our website, and we will respond formally to Nigel, who's raised the questions. So forgive me reading them, but it's so that I make sure I cover all of the excellent points that Nigel has asked us to shine a spotlight on. So the first question is, does the board fully accept NHS England guidelines about the provision of virtual wards, including the 9 principles? How many additional virtual ward beds are planned for Cornwall? Which staff will be expected to provide care, and how will this affect their existing roles? And what services will they cover in those virtual wards outside of core hours? So firstly, I thought I'd just explain for people who may not be familiar with the concept of virtual wards what they are. So the virtual ward helps provide an alternative and safe alternative to embedded care that's enabled by technology. Our virtual wards help patients who would otherwise be in a hospital bed to receive acute care, monitoring and treatment, but from their own home. In terms of the response to the specific questions from Nigel, the ICB board does accept the 9 principles of operating a virtual ward as set out by the NHSE guidelines. These include providing acute clinical care delivered by an MDT, led by a named consultant practitioner or a GP, having clear admission criteria and a daily clinical review, ensuring patients have clear information and delivering time-limited interventions. We anticipate by December 2023 that we will have 350 people will be supported by a virtual ward, and these will provide specialist care across the following areas: frailty, respiratory, cardiac, and palliative end-of-life care by December 2023. The way that our local model intends to operate, it would be both to help people be supported home from hospital when they've had a hospital stay, but also to support people in preventing them going into hospital and supporting them from their homes. And they will be supported by specialists such as our respiratory virtual ward, which is already established and is regarded what we said step up, so for people before they go into hospital. We are developing our model with our local GP leaders, our community geriatricians and specialist palliative consultants to support this care. And it's as part of that that we will be, as we roll out this model, understanding how that will change current job plans and what that will mean in terms of new roles and the impact it has for those roles. So we are still working that through fully. Work is currently being led by Cornwall Partnership Foundation Trust, and feedback is currently awaited from NHS England on our funding bid and rollout plan to maximise towards a 350 virtual wards beds. Chair, are you happy for me to go to the second question?
Thank you.
Yeah, okay. So the second question is the British Geriatric Society's use of virtual wards, social care funding and carer shortages. As raised by the British Geriatric Survey in their recent paper of virtual wards, how will commissioning decisions address the root cause of our current gridlock system, long-term underfunding of social care and a critical shortage of carers? So our response: the ICB board recognises the commissioning issues that are set out in the British Geriatric Survey paper on virtual wards, namely the impact of understanding your local population and geography, being clear about the care you provide and for whom, start small and learn as you go, and build on and integrate with the services you already have. It is also ambitious and optimistic about the effect that the virtual wards will have in supporting more people to receive treatment and support at home rather than in a hospital bed, and the impact that this will have on reducing pressures across the Cornwall and the Isles of Scilly hospital system. However, virtual wards on their own will not provide an alternative to long-term funded care at home, for which there is shortages, and so the ICB will continue to work to partners to address this challenge through a number of things you will hear about today through our 100-day plan and the work that we are having around our overall flow programmes.
Okay.
Thank you, Chair.
Thank you very much. So let's move on, if we may. The section on the minutes. So unusually, because we met on the 1st of July in setup mode, for having closure of the CCG and across, there was a board meeting for all of that and minutes for that, and then we had effectively our first board meeting in public on the 14th. So I'm going to deal with these in 2 bite-sized chunks of minutes and then come back and wrap it up. So if I could ask you just to turn then to the minutes relating to the 1st of July only. I'm not going to do a page turner. I think we're all grown up enough to have gone through that. By exception, are there any corrections that you would like? Yes, Steve.
Yeah, thank you. If I just make a couple of brief comments. Can I ask that my attendance is reflected the NHS provider partner member rather than the acute hospital provider member? And I won't raise that again, but that applies in the second section as well. On page 5, I think it is, secondly, under item 010, which refers to the committee terms of reference, there is a summary there, but I believe I raised the issue of the potential for a actual or a perceived conflict of interest if an executive director or the chief executive of the ICB was on the remuneration review group, and it isn't quite reflected in that way. So I just wonder whether I could ask if that was reflected. And there was a question.
Will that one first?
Yeah, sorry.
Yeah. Julie, could you help us there?
Yes, I remember you raising it as a conflict of interest, Steve. We then took legal advice on it and things, so I'm happy to tweak the minutes accordingly to reflect that.
Yeah, thank
Lovely,
you.
thank you. Trudy? Yeah.
Grateful for that, thank you. Apologies, John, I'm not sure if it refers to this section or the following minutes, but there was a note about the legal advice being shared. I don't believe it was. I think there was a verbal summary briefly provided, and if the minutes could just reflect that.
Okay, and I will take an action to share that legal advice immediately follow this meeting.
Absolutely, and then I just had one. Apologies, what I've read the papers in some detail. Just a question as to the minutes don't record who raises a question, and that might be appropriate, but the impact of not doing so is, if we look back, we don't necessarily have a record of whether a non-executive director is challenged or an executive director or a partner member. So I'm not suggesting we correct the minutes, I'm just raising the observation.
Okay, that's a really helpful observation. So what we're going to try and do, Steve, is it should reflect not the individual necessarily, but it should reflect sort of the status of that. So it would be a non-exec member. So if we agree that we're going to do that,
That'll be helpful.
yeah, happy with that? Good call, good call. We're learning by doing, everyone. Okay, anything else on the 1st of July minutes? I apologise if I swivel my head and don't get to you quickly enough. I'm trying my hardest. Okay. Okay, so let's move on to the 14th of July sets of minutes. Are there any issues for accuracy on that? Steve?
Just one this time, and apologies for that. Under point 033, which is on the performance report,
Which page are you on?
it is page 10 of 16, I think.
Okay, bear with me. Page
Sorry, on my electronic pack, on the hard copy pack, it's page 4, ICB 2223/033 performance report.
Yep.
My recollection is that I observed that the performance report was an NHS performance report and requested that future performance reports would be health and care system-wide performance reports, and I don't believe the minute quite reflects that.
Happy with that alteration?
Yeah.
Thank you.
Thank you. Noted. Good. Done. In which case, unless there are any changes, what we'll do is we'll move to effectively approving the minutes formally as an accurate record of the minutes of the ICB board held on both the 1st of July and the 14th of July. Everybody happy with that? Yep. In which case, that's done. So that's the minutes. So I'm going to then, I'm going to now raise, as a result of some of the things that were in those minutes, because we're in a living, breathing situation, of course. Some of the issues that have come out from that were just under matters, so I'd like to turn to Kate to help us there with some of the matters that have come out from that.
Thank you. So can I pick up a matter arising which relates to item 038, which is page 6 of the paper pack, and I suspect, Steve, it's page 12, is it, of the electronic pack? Reablement Apprenticeship Programme. The minute that's reflected does accurately reflect the discussion that we had at the board, and Hans' Workforce Committee paper that's later on in the pack reflects a point of time that we got to, but I've got a matter arising that brings us up to date with where we are on the 75 apprentices. I just want to start off by saying that I'm very grateful to Debbie Richards' leadership that we are at the point that we're at of being able to start to have our first cohort of 25 apprentices starting their course at South Devon College in November. There'll be 2 more cohorts in January and May, so by May we will have the full 75 apprentices up and running, and there is a possibility that we'll have 50 apprentices in January, but it is just a possibility. CFT are working really hard to try and make that happen. We've had quite a low number of initial applications, so through the work that CFT have done in the clay communities, they're getting out into our communities across Cornwall to stimulate some interest in the apprentices, and Debbie will bring back to future meetings an update on the progress with appointing to these posts.
Any questions?
Yes. Can I ask what assurances there are that this will not deplete existing care staff from within the services already?
So the original idea, so I suppose there can be no assurance as a a given because Cornwall's a fairly closed economy when it comes to workforce. And these apprenticeships they'll be at an apprenticeship level of, I think it's £13,000, which
with the new uplift.
£15,000. So for both Band 2 and Band 3 staff, they already earn more than that.
It's 75% of Band 2, I believe.
So for care staff, it won't necessarily equate well to the salary they're already earning. We are trying to target it at people who are not already working in health or care, so it's supply stimulation rather than denuding. If we're unable to do that, then one of the discussions we're having is whether we target our Band 2 and 3 healthcare assistants who are desperate to be Band 4 and 5 nurses, and that we would then use our community-facing recruitment to pull people into Band 2 and 3 posts so they get the structure of work before they get the structure of work and a college course. So that's the work that's going on at the moment. That's what's made it a bit more complicated.
Thank you.
Just before you come in, as the employer, can I thank CFT, Margaret and Adrian. Is there anything you would like to add to that before I bring in Rachel?
No, I think thank you very much for making it clear that that's how we've been operating and trying to do the best. Taking Mary's point very much to heart, we did not want to be robbing Peter to pay Paul, given the closed economy. So we were very careful in the way it was structured.
Thank you. Anything you'd like to add?
Just pointing out the success of some of the outreach programs we've had in the community, as Kate mentioned, in the Clays and others, to try to recruit people that we wouldn't otherwise reach. So very much taking that.
Will you pass on our thanks to Debbie?
Will do.
Will do. Rachel.
Was just connected to that, Chair. Is there anything we can do as board members or through ICAs to try and help that with that recruitment and that reach? Because I think we're all
talk to people. That's I think
get the word out.
Just get the word out, saying here's a great opportunity to learn and earn.
And our MPs have offered to flood through their constituencies, so if we can get it out to them, that would be great too.
Well, Chair, thank you. Do we know why the take-up was low? You referred to it being low, Kate. It's a real challenge for us in some areas around the region as well. What is there some specific issues that you're facing?
I think some of it might have been how the advert was made. So CFT took expert advice, and the expert advice came up with an advert that said, "Do you want to work in Bodmin?" Well, that wasn't the USP we particularly wanted. So the way that this is rolling out is giving us lots of learning points for how we need to do this in the future. And one of the things that we've talked about is how we do a piece of internal audit. That how could we set this up better? So we don't have a named SRO at the minute. That would be really good if it was somebody's job that all they thought about all of the time, not just Debbie, is how do I land this? So there are lots of lessons for us to pick up.
Brilliant. Everybody happy with that matter arising?
John,
Yes, Tom?
Oh, sorry, I've still got that one.
Yeah, and just to say that that's going to come back to workforce. We're going to have a more thorough look at it on the 20th of September.
Very good. Okay. Moving on. Trudy, is there anything else that came out of the minutes in terms of actions or matters arising that you would like to raise?
There was one on policies that I think Mari raised that Patrick was
Sorry, speak.
that Patrick was going to pick up about policies and how do policies relate to participants and members of the board that aren't actually employed by the ICB. I don't know whether you've managed to get an answer on that one, Patrick.
Not to update at this board, so that's still an action that we'll consider and bring back at a future meeting. Thank you.
Hey, can I just ask a question? Do we need to, does this, it picks up automatically?
Yeah,
So
just
colleagues,
need to be quite close to it.
just what I'm going to suggest to you is you just need to lean in closer to the mic and it will pick you up automatically. If you step back, it's not going to hear you, and colleagues on the call can't hear you. So modern technology.
Is it possible for me to just build on the point that Mary made, because I think it's really important? So when we're starting looking at things like confidential discussions that are commercially incompetent or relating to individual items and issues, I think that point around what policies we're working to is fundamental to the core of our governance. So Patrick, it would be great for our next meeting if we're really clear, even if it's our honorary contracts that don't have remuneration built into them, but that we're really clear about how that works.
Okay, thank you everyone. So let's move on. So item 5, which is the chair's update. So please take the update as read. There are two things I would like to tease out from it though. One is the away day actually that the Integrated Care Board had. So virtually everyone I can see around this table was with us yesterday, or most people were. It was I thought it was a fantastic day. I mean, to see so many different partners across all elements of the system coalescing behind, you know, not just what the issues are, because that's probably easy to do, but start to think about how we work together, do things differently. I thought it was an amazing day. But what were your reflections for those who would like to comment on? Any thoughts?
Yeah, I thought it was a really good day. I thought when you often think about the intellectual capital in the room, I actually thought we got the best of the intellectual capital in the room. And I did write to him because I thought Sasha's facilitation was really helpful. I think the thing I'm hoping that we do is that we're true to each other and actually take the actions. And that I think we can use the November meeting just to gently hold each other to account for not what did you do right or wrong, but how did it go? And I think that reflective, sort of more of that action learning mode of thinking. You know, I did something, or it doesn't matter whether it went right or wrong. I did it. This is what happened, and then that's what we can learn from.
Yes, Mario.
Thanks, Chair. Yes, I thought the day was very productive. There was a in principle decision taken regarding preparation for winter pressure.
Yeah, we'll get to that in a second.
And I'd like to just make the point, I'd like to see some developments on that quickly.
Again, I thought it was a fantastic day, great partnership working, really struck by how determined everybody there was to work together, to work differently, to put organisational boundaries aside, and particularly struck with the desire and the passion for voluntary sector partners to be engaged, to support and be a really, really active part of the challenges and the solutions that we face.
So one thing I would just add to that, of course, is that some people may have expected it to work well if you just had the NHS colleagues in the room. What for me was trebly impressive was to almost not spot the join between colleagues from the NHS, Council, the third sector, and all partners that were in the room at every level. It just, you know, from care home perspective, everybody I felt was on the same page. So we are going to come in a second. I'm going to invite the Chief Exec in a second to give one of the major outcomes that we would like to conclude and make a decision on today, but I'm setting that for Kate to resolve in a second when you get to her report. So the second element, before I move on to the forward plan, is there anything else on my report or that you'd like to ask? I think it's as it is. Okay, cool. So probably the more substantive element is if I could just draw your attention to the forward plan that's in here. Now, the thing that's important about this is going to be a living, breathing, changing, rolling 6 months forward plan, but gives this board and the executive group the understanding as to what we would like to see come back to this board for approval or for decision or for discussion as we go forward. So we can manage everyone's expectations in terms of priorities and strategies and those things that we need to decide. So if you feel there are things on here which are not right, we can amend them. And now is the time to discuss that. So Steve, I know, give an example. It's a shame that Ali had to step out, but if you look under November, I know you raised at the last meeting, wanted to get an update from the council on things like grants, and it doesn't say here the Better Care Fund, so it probably ought to say that as well. But it's important then that every partner realises, you know, what are they being expected to lead on to bring back, so they don't end up with a 1 week's notice thinking I've got some papers to pull together. It's complex because there are other decision-making forums, sovereign boards, sovereign councils, other partners we've got to do. So having some sight on this, I'm hoping will give people clarity. It will also give the ICB committee chairs the opportunity to work with their lead integrated care board executives to sort of say, there's a paper coming up in 6 weeks' time. How are you getting on with recommendations and that kind of thing? So for me, getting this site, and Mary, you kindly raised yesterday about making sure we join up with the thinking of other boards. I'm hoping that Trudy and colleagues like that can sit down and work this through. What's clearly key for us as a working, and some of the learnings I think we've all had recently, okay, is the importance of things coming through the senior executive group and through the committees on their journey towards here, and where we agree, we can all say that in the papers. Where we disagree, we can then be clear on where we disagree, and then we have the debate. Does that work as a structure for everyone? Because I think if we get the structure of this working and a rhythm, then it will flow more neatly. So let me throw it out there in a bit more detail, because there's no point doing this and then ignoring it and then doing something different for next month. Things might change, accept that. But as a direction of travel, let's just look at October. Well, bearing in mind most of the things that are here in in September. So the structure of this, I think, is important because it's the first time you'll have seen this. Try to break the things in terms of the forward planning into 4 key headings. The first one is around the 6 top priorities, and there'll be something particularly under the Transforming Care for Cornwall section that will feature around that, and you'll see on the right-hand side, on the 3rd section, a TC4C, Transforming Care for Cornwall update. So once we get the sort of strategy sorted, then we can start to sort of say, well, how are we doing in those sorts of things, right? So there's some thinking in terms of reporting, update and strategies. So on the left-hand side is where we're trying to think, by the time we actually get to Christmas, we'll have dealt with the service, I would call them the service line strategies. And then, Patrick, we start to move into January in terms of thinking about workforce strategies and that kind of thing. This is where we're starting the starter for 10, right? Recognising the next column, it's not undermining those, because if you take something like the winter plan, I would, that's hardly something just for tomorrow, is it? It's for today, and therefore what we're hoping is that we can have a system-wide coalesced solution by the time we get to the October one, and we can all be clear. And it's probably going to be more of an update because you're all working on it now, and particularly with the kind of conversation in your update, Kate, that will take on that. But also then the structure of updates. So whether it be finance, quality, performance, we'll be asking through Kate, because she'll chair the Transforming Care for Cornwall element that will oversee the top 6 priorities. We don't have 3 days to go through all this stuff. So there's something about we're structuring that the 6 priority groups then report into there that can be a written update that can come through to here. Rachel, you're comfortable with that?
Definitely, John, that works really well.
Thank you very much. I'm going to be asking each of the ICB committee chairs, again, to write their reports and by exception, comment on sections, okay? The one thing that's come up since we did this was the idea of actually giving the statutory partner members the opportunity to actually act in their capacity to give what I would call well, actually not quite called, Ali actually phrased it better than I did, a 360 view that we could all see. So the council could basically say in a half-page update through the partner representative, through Ali, here is the council's, please, council's update on here.
The aisle's silly, thank you.
Sorry?
The aisle's a silly, thank you.
Yes, thank you. So through you, that you're actually representing 111 and the whole provider side of it, so that you can write an update there, because we need to hear how 111 is doing and that kind of thing in the space. And we've talked, and thank you for all that. And Debbie, Adrian, I've spoken to Debbie, she's very happy to bring an entire mental health dynamic to it. And of course, Andy, you bringing your primary medical care partner view in here. And by doing that, I'm hoping that we'll all be cited on the different elements of it. And maybe the next one iteration might be with the 3rd sector and that kind of thing. But I'm trying not to drown us also in papers, but to try and give us a rounded view. So there's on a no shocks basis, we can get stuff. And sometimes in between papers and boards, any issues I'm hoping might be resolved. Okay, so that's the sort of thinking on there. And then on the right-hand side, the final bit on the right-hand side, of course, this is where nomenclature gets difficult. We are the ICB board, but there's an element of time when the ICB is the bit that's the smaller bit, that's got the 300 plus FTE in it and whatever else it is, and therefore it'll have its own little set of sections that it has to work as a silo on its own, to be honest. So we're trying to segregate those. Are you comfortable with that approach? Because the minutes, the agendas will be structured in that fashion.
Can I just check my understanding on the TC4C, which is quite cute, isn't it? So is that saying, so we're going to look at, next time we're going to look at intermediate care, but we're deep diving intermediate care. However, we will always have an update on the
106.
Yeah. Okay.
So the idea on the left-hand side is there's only so many strategies you can write in life.
Indeed.
Okay. So the challenge here is
that's fine.
the first one for October is about strategic priorities. So the first one I would really say in November is asking the executive group through SEG and come back to here is what is their strategy on flow and discharge? Yeah. And that's the strategy. Once we've agreed that, it moves to the right-hand side and then we start to get into a rhythm.
I get
that. But I think it's helpful for you to tease it out so we're all on the same page. We can be sometimes separated by common language. Yeah. So Kate, we'll look to you to make sure, and I know it's in the paper because I'm not quite sure we've quite cracked it yet, that you're going to want to maybe revisit that so we have a functioning group, and we need to think about the SROs for that so we've got clarity, Margaret, also as to who we're holding to account in there. Okay, so that's the rhythm. So without labouring the point, is there anything else on here in terms of the order or the content that you would like to see, particularly for the next one? Let's focus on the next meeting. Have we missed anything in here? Rachel?
Chair, given we are signing off and submitting our BCF at the end of September, I wanted to make a proposal that we bring the BCF update into October, please.
Okay.
Better Care Fund.
Thank you.
Better Care Fund.
Yeah.
So if we put that with the council grant update as well, because I know that's what you were particularly interested in. So the two of them, done. Yes?
Can I make a plea, Rachel, that we share that at the time that we submit it? Because once it's submitted, it's gone. If it's going at the end of September, I think colleagues might like to see it before it goes, so they've got opportunity to ask points of clarification or even to challenge some of the schemes that are in there.
We're also planning to take it to SEG prior to submission as line with the governance, but we can also share it with committee members in full.
Very good.
Not a problem.
Thank you. Yes, I can see that. Caroline was next.
Thank you, Chair. The ICB governance PwC review will probably need to be October because they won't be with us in November.
They've agreed to come in November.
Right, okay.
So if you take that offline, that's great. Thank you for that. Mary?
Yeah, I think Kate probably has made my point, but I just think it's that little piece of nifty footwork while we work out where all the boards and committees are, so that people get a chance, even if it's in delegated authority, to have a sight of something, because there may be something that we could add or something on other boards that we would need to change to accommodate it properly. So I think it is about just, I know it's a lot of work, Trudy, but it is about getting that sequence of board meetings or actually delegating to an executive and a non-exec to do that on our behalf.
Yeah, just following up on the what's called council grants, we're talking about Better Care Fund, etc. Maybe it needs to come twice. I think the first stage we're talking about is here's the proposal, here's what we've agreed, and we need to be informed. Maybe there's a 6-monthly cycle of and how's it going, as well as here's the contract.
We intend it to be regularly part of our finance and performance report in terms of the key, because for all of the schemes that we have, there will be an impact assessment and profile, so that's the intended plan going forward.
Life wasn't complicated enough. We just need to overlay this, our Rachel, with the other our Rachel, that's not in the room, Rachel Rotherow. The two of you for the Integrated Care Partnership, of course, are working on bringing that together as well. Yeah? Rachel.
Thank you. I just wanted to note that I see that the council agenda around those grants is on the forward plan and children's services, which I welcome, and sort of the work around reducing health inequalities. Just a point really on that, and I note what Rachel Connor has just said about it being a finance sort of discussion around the NHS grants, but wouldn't we better look at what is the outcome we're trying to achieve? That agenda item is about what are we trying to do? Are we trying to support the transformation of adult social care and look at how we're addressing health inequalities? It's not a sort of scrutiny of the grant, and it's not a finance exclusively. It's around what are we trying to do with that, and I think that's more important.
Well, I think Rachel's title is Director of Inclusion, brackets commissioning. So the performance part of the Finance and Performance Committee will be picking up not just how many, but the so what of it. So I want us to be able to link when we spend money, who we're spending it on, and is it the right part of our population. So that's deliberately baked into Rachel's job. It'll go through finance and performance, but it'll also hit quality at some point.
The point was about
it might be my shorthand for the title. So when I was talking about impact, it's impacting the round, Rachel, so completely agree.
So
it's the Ali's paper that I was querying rather than Rachel's.
Right, yes, no, I agree. It's just that they are technically grants. It didn't mean to be inferring the money bit. But can I just ask Steve, because this is a line of questioning that you've been asking for a while, do you think we're clear on what we're expecting from that paper?
I do, but just to note that the Better Care Fund requires approval by integrated care boards. So I just wanted to check the governance aspect as to whether that approval comes through SEG or does it come to the Integrated Care Board for approval. And I think the matters of fact are the Integrated Care Board and the local authority are both required to agree the Better Care Fund, and those plans need to be signed off by the Health and Wellbeing Board. So just really to test that we've got the governance timeline to achieve those matters.
Rachel.
John, my understanding is in June we gave delegated authority to Kate and Kate to sign off the BCF, but on the proviso that there was the consultation through SEG and the other forums to do that. So that's my understanding.
Happy with that?
And the Health and Wellbeing Board.
Just to observe, it's a significant sum of funding. It's about £48 million as the Better Care Fund. So that might be a matter for board colleagues in terms of that. And when we think of the £48 million in the Better Care Fund and the £33 million in the S256 transfer, collectively, that there is a very significant amount of resource. So I wasn't aware that had been delegated to chief execs or to executive directors, but I'm mindful of its scale and the impact that we should expect from it.
I appreciate we did that, but in the sort of collegiate way, is there any reason why I think one of the principles which we talked about earlier, which we should just come back to, is there any reason why it wouldn't go through the senior executive group SEG?
Definitely go through SEG.
Okay,
It is going through SEG, yeah.
So I think that's the first bit of important governance, which we've agreed. But is there any reason why it couldn't then just come through here for sign-off formally? Because it is these are big strategic stuff. It's not undermining, Kate, your position. It's just a question. There's an element of formality that.
So that's not a problem, but we would need to do that virtually, Chair, because there won't be another meeting here before the submission.
Are you happy to do that? Happy to do it virtually, everybody?
It's protecting you.
I think Mary was first.
Yeah, John, thank you. I think it's just about protecting each other. These are very, very large amount of money. This is public accountability. So it's not about not trusting people. It's about actually trying to stand together on decisions which we could and will be challenged on. And it would be rather nice that you weren't just there on your own, Kate.
That's where I'm coming from.
So I just want to be clear, and Rachel O'Connor did mention this, but there is a statutory requirement for it to be discussed at the Joint Health and Wellbeing Board as well. So there is transparency around the proposals, and that have been at every meeting in the last year, just for information.
Rachel, that's exactly why I was just making the point about the need to line this up with the Integrated Care Partnership as well, because the relationship between the ICP and the Health and Wellbeing Board and all the bits that still has to be worked through. So that's why I'm looking to you to make sure that you and Rachel Rotherow come up with. All the boxes have got to be done, but I want to not miss Mary's point here. There's something here about collective responsibility here, which once we all sign up to it too, it isn't just a couple of people in a room. This is we've all made this together, and I think culturally that's the right place to start. Okay, everyone? Okay, I think enough on that then. So unless anyone hears anything, if you do want to change anything, please get hold of Kate, because Kate, you're the owner of the forward plan now in terms of any changes from that. Okay, so as I set up the question about, or the point yesterday we made, had a great meeting, but we also, I think, came to a conclusion. Maybe you want to just kick off with that, but we'll move over to your Chief Exec's report.
Yeah, thank you. So you have in front of you just some thoughts that I've had over the last month around the work that we've been doing. I think I'd quite like to go through the report, and then we'll focus on the outcomes from the meeting yesterday, because I think they pull together for some strands that are in here. I think it is worth saying explicitly that both Cornwall through Royal Cornwall Hospitals Trust and Cornish residents who go to University Hospitals Plymouth, there are significant issues around access to urgent and emergency care for our residents that use both of those facilities. And Steve Williamson, in his provider chief exec role, and Anne James as the provider chief exec for University Hospitals Plymouth, have met with the previous Secretary of State twice to talk about how we're going to improve our performance in the short term swiftly to be able to meet the needs of our population. We also have a meeting this evening around our ambulance delays with Pauline Phillips, who's the National Director of Emergency Care. We continue to work on a plan for Cornwall that reduces the hold at the front door of the hospital, because that's for all of our people. And I'll come back to that when we start talking about winter. To support us in the work that we need to do in this timescale we need to do it in, we've had the support of a company called Prism, who've done a diagnostic report around us as a county, how we work together, and what we need to do to be more effective for the people that we serve. There's some comments on the back page which are a distillation of some of the things that they've found, but effectively our governance doesn't help us to move swiftly in an agile fashion. We lack grip over some of the delivery of our programmes, and when we come back to Transforming Care for Cornwall, I'll talk about that in a little bit more detail. We need to change the orientation of our system swiftly, and that requires people to move faster and to change quickly, which in times of operational pressure is really hard. So we are having a discussion between RCHT, CFT and the ICB around how we would potentially land additional support from Prism going forward. That isn't agreed yet, but it's a work in process. To support that, we've got PwC in with us at the moment looking at our governance as we move from a clinical commissioning group into an integrated care board. I think it's great that we're having detailed discussion around governance in our board meeting, because the whole of the way we work needs to be different from when we were a clinical commissioning group, and aligning the various processes that we're going to have to go through for proper collective agreement, I think is going to take some time for us to get there. PwC are focusing very much on our operational governance around how the operating model across Cornwall is working, and I am hoping that they'll give us some really good feedback around how we align all of our people so that we're all facing in the right direction, and importantly, we all understand how it works, because then that keeps us safe and it means that we can make quick decisions. I've just seen Adrian, so I've just remembered, it says I can add things in here as I'm going along. I had a discussion with Joe Rafferty, who's the Chief Exec of Merseycare, which is where restorative justice, psychological safety and just culture came from. Having spoken to Joe, who I've known for a long time, I now really get what he's talking about. So we provide the psychological safety for rapid change. We provide the restorative culture for rapid change, and the just culture so everybody feels safe in doing the right things for our people. So Patrick's looking at how we could pull together our exec teams. So we talk about what we do that nobody else does. So RCHT, UHP don't do social care. That's the responsibility of adult social care. We all own what's ours. We own our grey areas, and then we talk about the Merseycare way of working so that we can support our staff to do things really quickly as we go into winter. So this segues into our winter planning for 22-23, and we had a really good board development day yesterday, and I think we've come out with some collective decisions around how we're going to work that I think I'll play in now, actually, because it seems to fit in with the stream of our discussion. So my colleagues around the table, I think, are going to feed back on some explicit things. I'm just going to give some headlines. So we have agreed that we'll set up a coordinating winter room, name yet to be decided, for Cornwall, and that will be where we have the one version of the truth, the single data flows, the single understanding of what's happening end to end across care in Cornwall. And we're going to have a very clear focus on out-of-hospital care, because we know for our frailer, older, vulnerable people, not being in an institution this winter will be really important. So I just wonder whether people would be happy to talk about the individual bits that they took away from the board development day yesterday. I'm talking about the executive colleagues. Steve, I don't know whether you'd like to start.
Yeah, very happy to. And it was, as we've already said, a really positive day, and I think there were 5 or 6 key things that were agreed. Kate's mentioned one of them, a system coordination centre to coordinate work and response across the whole system. And I think Helen might want to give a quick summary of what we expect that to achieve.
Thank you, Steve.
You just need to lean in.
Thank you.
Thank you. Thank you, Steve. So what we're wanting to do is to make sure that we've got, as Kate describes, a single source of truth. So looking at data capacity, and that's not just bedded capacity, but also community resources and what we're able to do. What we would like to look at is obviously workforce, and as Kate's mentioned, looking at with obviously agreement how we could potentially deploy workforce to where that's needed. What we talked about was some of the areas where we feel that there could be a higher risk in terms of making sure that we keep people safe in the community. So around things like care homes and how we can support, but also around falls and frailty in terms of how to manage people appropriately at home, and obviously look at hospital escalation when that's required. As part of that, and that really fits in around that sort of safety aspect, is needing to look at a dynamic risk assessment across pathways to make sure that we've made those decisions now rather than actually in the sort of heat of the moment, although there obviously will be a lot of decision making within the coordination centre. As part of that, we want to be really clear, as was during COVID, around that escalation and de-escalation points, using data, using workforce data, etc., to decide around where there's an escalation and de-escalation, but also be really clear about where there may be things which we need to stop doing that may not be adding value in the immediacy of where things are going to be during winter. We know it's going to be challenging, but I think in terms of we're in a good place in terms of working together in that integrated way to be able to manage winter and keep our community safe, and also, as mentioned, care closer to home.
Thanks, Helen.
And I think we should be bold and to say that we are promising that nobody will be lying on the floor for 16 hours waiting for an ambulance. So our full service, we are going to be mapping its impact across Cornwall, and for this winter, anybody who falls, the automatic disposal will be to the full service, not to an ambulance for a Category 2 call. And we'll monitor that closely through this board, but that needs to be a promise to our people in Cornwall.
And that's really important and absolutely clear. And Helen's covered a range of the particular actions that we'd be intending to progress, and I think John will be looking for ICB endorsement for these 5 areas particularly, and Kate and Helen have touched on them, but if I perhaps just briefly recap. Firstly, ICB supports to progress with the rapid mobilisation of a system coordination centre, which would be our point of coordination across the whole health and care system. Yeah, so that would be the first thing, and
everybody, yeah.
Can I just stress the importance of those people with mental health and learning disability and that visibility? I think if we look at an analogous view of somebody falling and being left at home who's elderly, if we look at the situation in mental health and learning disability, that would be something like a care package falling over and people being left with unsupported for a long period of time. So that same visibility will be required for that coordination centre.
So I think the analogy with falling is a crisis service. So we need to be really clear that our crisis services are available at the hours when people are going to need them through winter. So I think it's absolutely important that we pick that up.
Thank you. Will.
Fully supportive from a SWAS perspective. I think it's a great idea. I've seen it work live only 2 weeks ago in a part of the region where we had a room not dissimilar to this size with every single member of the pathway and the system was represented in that room. We had someone in the room. I would ask that we take a similar approach, Chair, and very definitely we want to be involved in that. So fantastic initiative.
Thank you. And is it 24 hours? Or?
Yes, there's certainly been indication that we need to cover this for 24 hours, whether we're expecting everyone in the room during that time or whether they'll obviously be on call. But yes,
how busy we are.
Absolutely. So it would we would be standing it up initially, obviously during the day with potentially on call, but we obviously may need to escalate that to a 24-hour.
Absolutely, in principle, it should be 24 hours, I think. The challenge we will face, which is for me to sort out, not you, is one of resource, given that actually when I look across the region, there are probably going to be 7 similar systems standing things up. But that's for me to worry about, not you.
We've got an agreement on that first point. Yeah, please minute that. Thank you. Second
Perfect, thank you, that's really important. So the second one is as a system to progress with rapid discharge home for assessment. So this relates to those patients who are in acute or community hospital beds who finish their medical hospital course of treatment and are waiting to go home with social care. Council, CFT and other system partners have been working really closely on this, and really the principle is similar to rapidly moving patients out of an ambulance into an emergency department and rapidly moving patients from an emergency department into a inpatient bed. We also want to rapidly move patients back into the best place of care for them when they've finished their hospital treatment, which is at home. So that ICB support for a discharge home for assessment, and I'm not sure if Rachel or Ali would want to add anything to that.
Thank you, Steve. So I think this has been an important part of our improvement journey, but this is about us actually getting rapid pace around making that change. So this would be absolutely that. And actually it's important for our people that they are a home and can maintain their independence as long as possible. And I think this is crucial for us doing that and doing well by them. So there has been planning meetings this week and we are looking for implementation on that from next week. So it's that rapid in terms of our pace.
I just want to make sure everyone understands that this is where there's a huge risk in the system for doing this. Don't get me wrong, I'm 100% behind it, but this is where we get nervousness from our people on the ground about, they know they're never going to get blamed for keeping people in hospital, but they might get blamed if somebody goes home, falls, dies, and they are scared about that. So I think we need to make sure that we communicate that we've got their back. And I think it's useful to think about deprivation of liberty in the sense of if don't need to be in hospital and we're not letting them, quote, go home, then is that not a deprivation of liberty issue?
So we picked some of that up yesterday, Margaret, at the away day. And Ali Bullman's not in the room at the moment because she's out of the room doing exactly what we're talking about now, making sure that we're freeing up the back door of hospitals, but also the back door of Home First and the back door of Steps. So we have very, very long spells of support for some people and nothing for others. And we do know that there's national and international evidence that the longer you stay in an institution as an older person, the less good your treatment and life outcomes will be. So yes, we are looking to transfer risk, but it's for the right reason, to keep as many people as possible happy in their own homes.
But they are afraid. I mean, that's...
Hello?
And I think that's what we are talking about in terms of that dynamic risk assessment, to look at where risk actually sits, and the assumption that that people are not going to fall, or that there's a safety in terms of keeping people in hospital. And as Kate obviously has touched on, we know that outcomes for people, if particularly older people, if they stay in hospital for long periods of time, is not good to getting back to their own home. So it is around that dynamic risk assessment and making those decisions.
I just want to make sure everybody understands what I'm trying to say, which isn't about that it is the right thing to do, because we're clear on that. We know all the reasons. Okay. It's the concern that raised by the individual members of staff that I want to make sure that they know we've got their back around this table.
Susan.
And Margaret, it's a point that Kim and I are picking up next week. We're talking to regulators, we're talking to unions, we're talking to professional bodies around professional standards, not as a stick to beat people with, but how do you protect individuals from making decisions that are very difficult to make. So that's a piece of work that I've also hooked into Sue Henny at Region about as well, and national reps.
Yeah, thank you. I'm mindful that Ali isn't able to be in the meeting today. We've had a number of discussions with Ali in the last 12 hours. I just would want Integrated Care board members to be aware of her individual personal support for this alongside our other executive directors. So she was very supportive of rapidly progressing mechanisms and capacity to enable rapid discharge home for assessment with Home First support to release hospital bed capacity. So although she's not in the meeting room now, she's been absolutely engaged, as all partners around this room have, in progressing that.
I think there's something about where we think the risk sits and then where it's felt to sit. And it's easy for us in a position like this to underestimate the gulf between the communication message that we may give that we've got people's backs and how that's felt close to where care is delivered. So I think it's really important that we think about very carefully and consider the resourcing about how that message to our population, but also to the people making decisions face to face with our population, is coordinated. We've discussed this at SEG, but important to share that message here.
Bearing in mind I'm conscious of time, and you're on our second out of 5. But Neil.
Thank you, Chair. Picking up on what Adrian's just said, I think it's important to reflect that throughout the day there was an emphasis put on the fact that whilst we need and must have coordination at the centre of this to ensure that we work as a system efficiently, we would be building on the frameworks that already exist, and some of this is about integrated team working at place, and we've got good examples of that building. So if we take the one system, the 3 ICAs, the 15 PCNs and the 31 emerging community hubs, we have a framework to build on that the centre can coordinate with, and that risk is managed well when people are able to work as teams and share some of that risk.
They're on what we've agreed. We are. Item number 3.
Excellent, thank you. It's already been mentioned the importance of having a absolutely appropriate 24/7 falls response service in Cornwall and the Isles of Scilly. So, as Kate briefly touched on and Helen said more about, our third intention for ICB support would be to implement an enhanced falls service that never lets the kind of example that Kate described earlier on happen, which will be health and care providers working together to provide an enhanced system falls response service to provide a timely response and rapid support to falls victims, to ensure that falls victims don't remain on the floor for many hours whilst they await a ambulance response. So the nature of that response may be such that there could be a falls response in advance of a ambulance response, and be working very closely with SWAST colleagues and partners on this as well.
Oh, yeah. Steve's absolutely right. So we are working closely. It is absolutely supported from our perspective. Well, what I'd ask is that work, as we fine tune it, we get into the detail. What we are trying to do from an ambulance sector perspective is provide one model that is consistent across all 7 parts of the region, because we're doing this elsewhere. It's unhelpful for us, and it makes it more difficult if we have very different models. So that would be the plea.
Sure, thank you, and I'm sure everyone would support you on that then.
Thank
so
you.
Item number 4, commitment number 4.
This is a commitment to expand care home support from the NHS into care homes, and there are a number of organisational process, funding, bureaucracy and other barriers that have in the past not enabled or supported that. What we want to do is build on the existing care home support teams that we have to further enhance that and provide enhanced health support to care homes to support residents to remain at their own home rather than coming into hospital where possible. Of course, there will be times, right, when care home residents will need to come into hospital. That will, John, be particularly for some of those people, residents with greater needs, dementia, mental health, learning disabilities and other vulnerable areas. So there'll be a particular focus on there so that we can avoid the only safe place in the system being an emergency department.
Can I ask a question on that one?
Yes, Mary.
Or a comment as much as anything. Sometimes when someone we're accepting delegated health responsibilities through that route, our staffing levels make that a challenge, and I don't hear that being talked about. We're happy with those delegated responsibilities, but if you are working on I won't say skeleton staff, but very limited resources of staff, and you have to leave somebody in that supported situation for a lengthy period of time, then we may be short elsewhere within the care home community.
Thank you. Kate.
So I think, Mary, that ratios of staff to patients is something the whole of our health and care system is going to have to pick up as we go through winter. And again, it would be something that I think Susan and Kim will be raising both with our local professional leaders and our national professional leaders. You'll remember we did all the workforce planning in terms of COVID around intensive care. This winter we need to do the workforce planning around in your own home, which includes in care homes. And then the second point is that we're already starting to expand Louisa Forbes's care support into care homes, because we did say yesterday that one of the really wonderful things would be is if you've got a chest infection and you need intravenous antibiotics and intravenous fluids, you could have them in a care home and people could come in and support you to do that, so we don't move people unnecessarily. So all of that will be built into the model, and I think your issues around paucity of staff at times over winter is something that we are all worried about and we all need to support each other on.
Thank you. And Patrick, based on yesterday's conversation, working towards potentially how we have a system view of workforce might actually be helpful as we pick that up.
Yep.
think we're coming on to 5 now.
Number 5, sorry.
Excellent, thank you.
I was getting too eager.
And that final area is recognising the kind of challenges that Mary and Kate have touched on. So this is less defined, John, as an outcome at this stage, but to urgently develop options to provide support to staff across our health and care system in this exceptionally operating environment. So 5th priority around health and care staff support. And I might just see if Patrick would want to start with a brief summary.
Just a bit of context, if I may add, to add to the importance of this. So we had the Cost of Living Summit on Monday, which reminded us that our staff are our residents, and under those pressures, so they'll be under pressure at work and under pressure at home. So there's something really important for us in terms of the tone we set for inviting flexibility. We're going to be requiring flexibility and the support we build around our health and care workforce to work in a way that's going to support this. So I just wanted to add as well, I'm working on the assumption that a priority of this nature means I can call on, or we can call on, the collective workforce teams across our organisations, and I just think it's important to flag that we may need to juggle priorities in that light.
And just before I bring in Mary, how do people respond to that challenge from Patrick?
Could I just raise a concern, which is I would be all for it, but we don't have slave labour. So I think it might be, we need to be very careful how we approach.
That's the point I was making, I think. Yeah.
Do you want to just exemplify what you were saying? Because I think that's important just to...
It built exactly on that this is going to need a really supportive effort to pull the best out of our workforce. That was the point I was making. Yeah.
Thank you, Patrick.
I think Steve was going to respond to that point particularly.
Yeah, so from a provider perspective, we've had exactly that discussion with all providers who were engaged in the event yesterday, and I think there is strong support, Patrick, for all providers to work flexibly in this extraordinarily challenging position that we're in. However, staff are clearly under exceptional pressure, and some staff may not wish to work in a different area. So what we would be wanting to do, I think, is approach this in a way which provides the mechanisms where staff can be redeployed, where they can be supported to do that, where they would wish to do that, but recognise that we have contracts of employment, and of course we can't, nor would we wish to direct staff to work in a different profession or a different organisation.
Build on that, or?
Yeah, thank you. Just very briefly, because Patrick's already said it, I just think it behoves us as a board to bear in mind the economic context in which our staff are working, and maybe think even more laterally around how we deploy people close to where they live. And thinking about that really excellent scheme, thank you to the council, where you've got all the buses lined up now, and it's £5 for a whole day anywhere you go, I think, £20 for a week. I think we need to think about how we use some of those initiatives to facilitate what our staff do. And then the second point is, I think we need to think about how we recognise what our staff are doing, and it's not necessarily monetarily, although clearly I've just touched on that. There's something about that pride in people doing what they did for COVID, and how we think, and you're right, Patrick, it's the tone. It is an ask, it's not a you must, it's a please will you help. I know you'll help, I know you'll help your neighbours, and I think it's if we can focus on neighbourhood and locality, that will help people.
Can I just also come in? Some of you know that I've already taken on some Filipinos. The trouble, they are amazing workers with a cheerful work ethic. I do think that could be expanded by other people. Accommodation is the problem, and we talked a little bit about that yesterday. And I do think that would help us in time for the winter.
Okay, final word from Kate on this.
So Patrick, I think you're also asking for management resource in terms of driving this. So bringing teams together through one clear focus, which is the priority around workforce and winter. I think you weren't necessarily talking about our workers who are in service. It's
correct.
Our managers who are in service.
And workforce teams to support the collective effort. Yeah.
Very good. So I think we have supported as a team those 5 items, and we've minuted that. Trudy?
So we are supporting that we'll set priorities so that Patrick can pull teams together, because I think that's what he's asking for.
Well, we'll all need to,
Yeah.
under the coordination centre. But yeah, it's the principle for workforce as well.
Because I may have jumped the gun.
We are supporting that, and we spoke yesterday, and it's right to record now, that we will coordinate the way our boards line up with all of this so that we can report to the boards this agreement between us, and then the boards can also put in whatever their part would be. So it is possible, and I looked at it all last night. They do line up, Trudy, just about. We can make it.
If I can ask specifically those members of SEG to make sure that when you have these conversations, you're cited on all the dynamics that need to be here, not just here, in order to get a collective agreement. Okay. Did you want to add something else?
Just very, very briefly, mindful of the time, and Mary's started the issue. Clearly wouldn't normally bring a verbal update on issues of this significance to this board, but this arose and was developed rapidly out of the away day yesterday, which is why there's a verbal update, which is why we're looking for support in principle from all integrated care board members for these 5 areas. Then we would rapidly be progressing this, putting in place the kind of detail that Patrick has described. Where there's a governance requirement, that will formally go through provider organisations where that's necessary. I think it'd be really helpful if a detailed report came back to the next integrated care board, which provides the clarity on all of those aspects, and that would align really well with the BCF aspect, because there may be some kind of funding or other opportunities that would
You
align.
have to work with Trudy to make sure that you're satisfied in terms of the timeline for the forward plan. Trudy?
Just one thing from me, please. I just want absolute clarity that CFT signed up as well, please, Margaret, just so...
Oh, yeah.
Yes.
Sorry.
Okay.
Yeah.
I think we've got unanimity, if I can say the word. Okay, so just thank you for setting that up. In terms of that was a verbal update. When we wrote the agenda, of course, and had the time frame and everything else, we hadn't expected to have such a wonderful moment yesterday and have such an important update. So with your support, I'm going to make a suggestion. Built in 15 minutes for a comfort break later on. Can I make a suggestion that for those who would like to grab a cup of tea or have a natural break, you step out and we continue on? Is that okay as a mechanism? Because I want to give due time to the others rather than cut them short. Is that okay as an approach? Yeah? So whoever wants to step out from now until we formally break, step out, don't feel bashful, but I'd rather use the time for those, if that's okay.
Sorry, John, I'm just looping back to the 5 areas. In light of some of the other papers that we're going to talk about, I think the other next step, Steve, through SEG is we get rapid the programme management set up and plans in place linked to the winter plan that makes this happen. So I just wanted to just check everybody was comfortable that this has to be our way of doing things and really getting into the detail and making an active plan.
Everybody signed up to that, I think, but thank you for... Sometimes it's important that you say it, and say it. So we're all clear. Okay.
So Margaret's just asking where PRISM fits into this. And the thing about PRISM is they are generally looking at flow. Flow in, flow through, flow out. So in terms of the priorities we've set ourselves, we look like visionaries when we now look at winter. Then making sure the flow programme is set up properly will be their bread and butter.
Very good, which is a perfect setup. Thank you, Kate. For the next item, nothing else on your Chief Executive
I just
report?
wanted to mention NHS
Can you be
Property
really
Services
quick?
really fast.
Quick,
So Debbie and I met with NHS Property Services, I've forgotten the Chief, Martin Steele and James Page last Friday. We're going to ask them to do a survey for us around all of our NHS Property Services across Cornwall. Got lots of it, and then we're going to superimpose our strategies and plans on top of it, make sure that they align with the property that we've got, and then start talking about whether we might have some choices to make around disposals, alternative uses, or how we use estate, acknowledging that estate is an expensive commodity and we need to use it well.
Okay.
Sorry, just a quick one on that. Is Simon going to be involved in that, and will that be updated through the Finance Performance Commission?
So I've asked them to send me a proposal that we'll bring through F&P. And once we've agreed the proposal, we'll ask them to do the work. And then coming back through F&P, as part of aligning our strategies, we'll work out what we want to do with the insights they give us from the work they've done.
Thanks, Chair. Can I just mention that part of the central ICA workstream has been estates and some concern over need for such. Is it possible that we can link that work in with the ICAs and make sure we're not missing any thoughtful service development that might need the estates.
So I've got Margaret in one here, because most of the NHS property services currently is for CFT service delivery. We have part of the discussion we were having is where we've got ICAs, there is a little bit of NHS property services, which is general practice, not much, but a bit. We also have lift developments that are also general practice, and we've got PFIs that are in a CFT. So it isn't just the NHS property services bit, it's the whole lot. And individual boards will also have a view around how this aligns with other strategic plans that are already in place. So that this will bring to light our strategic estates plan for Cornwall and the Isles of Scilly. So St Mary's will be included in it too. So once we spec the work out, we'll take it through finance and performance, and then I think we'll loop back through provider boards and then bring back here for a discussion around next steps, if that's okay.
Okay, so I'm going to push us on, if that's okay, else we're going to run out of... Is it really quick?
It is really quick, Chair, but I just thought on the back of Steve's 5 priorities for winter, whether just a very quick update on how the voluntary sector is stepping up to that, if that's helpful.
Do the winter plan?
Can we do it later on?
Do it later on,
Yeah,
that's
yeah,
absolutely fine.
yeah, else we're going to buffer out other papers, okay. So happy to capture it later on. So we're going to try now and move on to the next item. It's a big ticket item, to say the least.
Another one.
Another one. So what I'm keen to do is, again, I'm going to ask you, think about the fact that you've already read this. Rachel, I'm going to hand over to you and Helen to take us through this. But I think it's really important that we spend as long as you need on it, but please don't present it and allow no time for debate. I would rather actually allow people to have the discussion on the paper rather than you present it, because it could take you half an hour just to present it. So over to you, however you want to do it.
Working okay? Lovely. So this is an update on our 100-day challenge, which is to ensure that we've got 0 ambulance holds at the front door of our EDs. I'm just going to make a few points from the paper, and I think it's really important that we get into the debate. The first thing to say is that there has genuinely been a collective effort across partners to do a small number of things that we believe that will make a difference. Sadly, some of those things are only just coming online, or we need to make a significant gearing chair for those to have the impact that we need. We are by no means where we need to be in terms of that reduction, both on ambulance holds and the CAT 2 time frames for response times that we need to. We had a good week last week, but we can't have one good week. It has to be a consistent good week for our residents, so that we reduce any avoidable harm that they face in the community. So the first thing I want to say is we are by no means where we should be, but there is an absolute commitment that we go harder over the remaining days of the challenge to make significant inroads into that reduction. And some of the things that Steve has talked about are significant components of things that will rapidly make a difference. The second thing to share is that we've shared in the paper the things that will have been completed within the next 2 weeks. That 2-week deadline ends on Monday. The final element of that, which is going live, is our low-risk chest pain pathway. And the one area that we have some slippage on is the individuals that are being supported by live-in carers. We have 5 out of the 30 going live, but those are, again, there's been escalated action to match more of our patients to those by the Monday deadline of those first 2 weeks. And the other areas in the paper talk about those that are still to go live over the remaining month, so the final month of the challenge. The final thing I wanted to say before I hand over to Helen is to recognise that we have had in the region of £11 million investment across the ambulance handover plan, and £7 million of that is to support additional capacity that is either bedded capacity or equivalent capacity that would reduce admissions to hospital or reduce length of stay. Again, in the spirit of the findings that we've had from PRISM and others, we have requested detailed plans, impact assessments, and I'm working very closely with Joe Davis at RCHT to model the impact of those investments going in, impact of those changes, so we can to see what that does will for the actual make a change in the trajectory on our front door holds and specifically our CAT 2. I'll probably leave the main points there from my perspective, because I think it's really good to hear the debate and challenge for the paper.
Thank you, Chair. I think really just to highlight that although this is a 100-day challenge, a number of the things that are happening in this are adding to the learnings that will be moving into winter. So if we're taking things such as the dynamic MDTs, multidisciplinary team meetings, there are themes coming out of that we're making changes for patients right away, but also things that are going to be working particularly at place, which has obviously been mentioned before, because there are a number of initiatives that are happening at place as well as looking across the whole system. Also, it discusses there, refer to page 5 where the different challenges are there, and that risk harm matrix that we've talked about in terms of that dynamic risk assessment. We have kicked off some of that around that risk and linking into professional standards, but obviously we'll be expanding that as we head into winter so that we look at more pathways.
So, you have the paper? Will.
Thank you, Chair, and to both of you for your comments, which I completely support. To Rachel's, I think there's been a huge amount of work done over the past few months collectively, and I'd thank everyone round the table and all members of the board for the work and the support that they've given my organisation in particular. There's no doubt over the past few weeks we've had some really good weeks across the region and in Cornwall. 2-3 weeks ago, across the southwest, we lost 9,500 hours in 1 week, and only last week it was down to 5,200. Now that's clearly still not where we want to be, but it's a step in the right direction. My point is, this week we've started to regress again, not just in Cornwall, but in other parts of the region. And I think it's really important, if we're going to move with speed and agility, we need to understand what we have done over the past few weeks to get us to where we were last week and before then, and why, and what's making the difference this week. Because yet again this week activity levels are relatively low. They're certainly lower than we would anticipate them to be. So I think it's a bit of a challenge to all of us to understand what has made a difference. Thanks.
So that's a really important point, Will, because I think those of us who've been around in Cornwall for a while have seen this pattern. We've seen the pattern of a need, a crisis or something that's really urgent, and people really step up to it, and it's great and it works well, and it slips away. And and we talked a little bit about this, didn't we? There is something about how we sustain that culture shift so that people think that urgent is a word that actually means BAU. You know, it's this is how we are around here. And then just, John, forgive me, but there was an absolutely brilliant piece on the radio coming. It was a very long journey, but people were talking about the difference between people who speak loudly, we can all think of them, and the people who are moderate, and why moderate people don't speak up, because they're ashamed to offer a moderate view. And there's a lot more to it than that. But I thought, what an interesting concept. Given what we were thinking about yesterday, how do we approach our moderates, if you call them that, to get those messages going, I think is part of that culture shift. But it's one, and Patrick, you're the one in the room, I'm afraid, but it's for all of us. But it is actually one that I think we really have to, grasp this time and not let it go until it works.
Karen.
Thank you, Chair. Rachel, you talked about learning, so I just kind of want to pick up that in the fact that we've got the 100-day ambulance plans. Obviously, we've got the winter room that we've signed up to putting into place. That's the here and now, and one of those things that you've talked about is we need some rapid learning from that, because actually what we need to think about is this going to formulate how we handle next winter, which kind of plays into our long-term plan refresh and also our joint forward plan that we need to have from December onwards. So we need to really be thinking about how we build those things into not only the here and now, but those longer term strategies and plans that we're developing as we speak.
Couldn't agree more, Carolyn. I think, and actually it was a bit of the reflection that we had yesterday in the away day, how we really embed our quality improvement approach and our PGSA cycle. So actually we rapidly test something, and then we know from some of the other systems, so South Warwickshire, that's how they do business in terms of that implementation. So I think, some of the things, my reflection from yesterday in the away day is that actually if we get it right with those things, those are the things, actually the major building blocks for the rest of our long-term plan, Carolyn.
And so I think there is we're going to get national support for this, aren't we? So there will be an expectation. We have a single quality improvement model for Cornwall and the Isles of Scilly, and that QI model underpins our transformational pieces of work, and that's driven by our single understanding of our data that through the how we understand issues across our patch. We haven't got the letters yet, but we know that they will come. One of the things I just wanted to pick up, Mary, is your point around, we're great and we're not, we're great and we're not. Some of it is the routine application of boring process, and that we sometimes lose the edges of the process that finishes it off when we are in less of a busy time. So my analogy is when you're running a ward, when it's quiet, nothing gets done. When it's busy, everything's done, because people all just take their foot off the pedal a little, and we need to recalibrate how we see tasks we need to do.
Okay.
Thank you, Chair. A couple of questions, actually, if that's okay. The paper references additional adult social care capacity that's been brought in. I just wonder if you could expand on that slightly, because that's an interesting development. Seems to go against current trends. And just a more general question, if you are able to implement the paper, the 100-day strategy, what do you think handover performance will be at the end of that period?
Shame Ali isn't here, but I'll do my very best in our partnership style of working in terms of the adult social care. But certainly the investment that we are making with the additionalities, some specialist dementia beds that we know we are short of. That's part of what we call our Pathway 3, which is due to come online in October and into November. The Discharge to Assess work, which is significant in terms of the benefits you can bring to our people and in terms of those processes, as well as, and I absolutely echo Steve's point about the tremendous work that Ali's doing in her leadership role around really taking a deep dive and fresh look of, as Kate has said, some of the BAU processes that extend to all of our sectors of things. Actually, although they may be small incremental gains, they are having an impact, Mario. So those would be the things from the adult social care perspective. Did I pause there before the second one?
Thanks. It's a really important question, Mary. I'm certainly grateful for that. I'd recognise, John, firstly, the huge amount of work that's already been referred to that did enable a temporary improvement in ambulance handover and Cat 2 response times. And I think we should recognise that, and we should celebrate the work of our teams across the system who've been involved in that. As Will said, though, performance has deteriorated. So the performance yesterday for Category 2 response times in Cornwall was 134 minutes. That's more than double what it was a couple of days ago. So we need to be absolutely clear on the scale of the challenge. The social care question from Mario is helpful, and I just wanted to emphasise the critical importance of one of the areas of work we've already agreed, which is the discharge home for assessment. There are currently, as of yesterday, 89 patients in Cornwall hospital beds across Royal Cornwall Hospitals and Cornwall Foundation Trust who are fit for discharge home, 89. To come to Mario's question, Mario, if we could discharge half of those, then we would almost immediately get back to an 18-minute ambulance response time. So all of the other things that we need to progress must continue, but we do know there are steps and there are opportunities, and it's really, really positive to see the agreement from before.
Can I just offer a couple of challenges and questions? Maybe it's one and the same, I'm not quite sure. How do we evidence what's changed to be able to understand the levers? Because anecdote on top of anecdote probably won't help us empirically. So how do we go and sort of say from 10,000 to 5,000 is material enough to be able to understand what interventions did we put in place? And I know we can't be specific that says 13% change because of this, but if we knew it was nearer 13 than 93, you get some sense of the magnitude. So how do we plan on unpacking the evidence that demonstrate what the key levers are? So I'll just leave that with your thought for a second. The second one is probably more aimed at Helen and Rachel in terms of, love the paper, think about it from the scrutiny chairs and ourselves just for a moment. There are certain elements in there like reducing P3 delays from 57 to 18 and hold at 18. We can see whether we've achieved it or not. So I'm still slightly unclear from the 100-day stuff in terms of the metrics that we know what does success look like, or the levers that make it? That leads into my first question. So that's my first observation in terms of the metrics and the evaluation of the changes. And the second challenge I wanted to throw in is one that probably we will develop as the day goes on, which is we have a winter plan, a flow and discharge strategy, 100 days work, a top 6 priorities programme board, an urgent emergency care group. I mean, personally, I'm struggling just to keep up with all the strategies and interventions, etc. So could we possibly start to think about, which I'm sure you'll come on to, is how we actually might simplify all this. So maybe you shouldn't have to accept that the chair is the lowest common denominator here, but I try and act as like someone who's a citizen as well. I'd like to be able to understand it. I do, but if I was somebody out there, I'd like to be able to get it. And also every member of staff should be able to sort of see how we get it too. So is there some way of condensing some of this stuff? I mean, it was right and fit for purpose when we set off on the journey, but as we've gone on the journey, we've picked up some decisions and key points. Could we really look to just be really simple, bring it together all into one, look to how we're going to maybe re-event, and we'll talk about this as time goes on, the 6 priority teams, how that's going, who's on those SRO, who's the SRO, who's focused on that, how does that link into this, and then so those are the 2 questions. How would you like to respond to those 2 challenges?
So I think the first thing around causality is really interesting. So we can see our graphs of things going up and down, but we've never got the line on the graph that shows where the intervention was made, so that we can start to plot that over time. And we do need to have that. And we know that some interventions take a longer run-in time than others, so that would be helpful for the board. And I think we need to use those SPC charts so we can start seeing where a statistically meaningful change is taking place. The second point around pulling everything together, so some of the so flow was our internal thing that we were going to do. Winter is all of it, and the 100-day challenge was given to us as a QI improvement methodology. Your point's really well made. I think we bring it all back together through Transforming Care for Cornwall, because the Urgent and Emergency Care Board is sort of the portfolio board for flow. The Planned Care Board is the portfolio board for elective recovery. So we can put a governance structure in place that makes sense to everybody.
So would you be, as a group, content to pick this up under the section under Transforming Care for Cornwall when we talk about the 6 priorities and how we focus on those that flows from the flow and discharge and 100 days? Should we capture that then? Sorry, I didn't see that. Yeah. Carol.
Thanks, John. Just in light of Kate's response and your lead up to that, I suppose the questions for me as a citizen and chairing the citizen engagement panel and committee is, what do we want our citizens, our public to know, and what do we want them to do? Because if I was watching this, I'd be saying there's lots of plans, lots of strategies, what can I do? And we're not going to get the answer here now, but I think it's in the back of our minds, but I think it's important to say that.
We talked yesterday a lot about narrative, and that's something which once you've got your mind around this, I think then how you think about how you push that across is important. And Mary, you raised this too yesterday. Kate?
So I think we need a comms strategy that's got the engagement with real people in Cornwall at the start of it, so that when we deliver our comms strategy, we know that we're delivering it a way in which will have resonance with people. So part of the work in the afternoon yesterday was around picking up our single narrative that we can all sign up to. But also we need to get out and we need to talk to our stakeholders, statutory, media, and also our people. So we haven't got the strategy yet, but we will have.
So Kate, maybe you could just help everyone. I mean, unfortunately, you and I have chatted a lot about it, so I understand it. But later on in the papers, you actually talk about, in terms of some of the governance stuff, about clinical leadership, but also having the voice of the citizen in the reign. Can you just touch on that? So we join up the dots between this piece of work and then that governance work later?
So I think part of the challenge for us is how we bring our governance to life, which is why the paper that I've written is sort of like making it work. So we are going to be genuinely clinically led. So we will have a broad clinical cabinet that spans practitioner roles through whatever sort of clinicians into biomedical scientists and people who traditionally we wouldn't involved in a clinical leadership forum. But we also want the parity of having a citizens leadership panel. So rather than us having the professional knows best, we have a dialogue between people who have expectations around care, people who have evidence around care, and then how that comes together in terms of a maybe a negotiated agreement, maybe a debate. So they will work together, be supported by our Clinical Priorities Advisory Group. As a strategic commissioner, we have to use evidence-based for population impact for our commissioning decisions. So we will want to take from the citizen leadership panel, from the clinical leadership executive, and CPAG will need to drive recommendations that we as a board receive, acknowledging we may not make all the clinicians happy and we may not make all of our people in Cornwall happy, but we will have a process that we can explain and understand.
Do you have a view when Citizens Priority Advisory Group, the CPAG, will be set up?
So CPAG is Clinical Priorities Advisory Group.
Advisory Group, yeah.
Yep. So I am making contact with somebody who's set 2 up already to come and help us. It's quite a complex bit of kit, and we'll have to get legal advice over our frameworks that we put in place.
That'll come back to here.
It will come back to here, and I'd like it to be in place by the end of October. I don't know whether the people I want to do it will be available in that timeline, but I'll
come
try.
back through here, so everyone's got a...
We need it for next year.
Yeah, no, I get that. Okay, so I'm going to look now to Rachel and Helen. The paper asks for input and thoughts on that. Do you feel you've got enough out of this discussion and feedback?
Thank you, Chair. Yes, and it actually it aligns with the UEC board around that one data set and making sure that we've got sort of lines as to when things were brought in. So that's already being worked on. We do have key performance indicators, but I think what's come out of that is back to the causality and making sure that we've got that and that data is being worked on.
Just to say, Chair, I think this the synergy from yesterday's away day is really important, I think, to bring together. The other thing I just wanted a little bit of a moment spotlight on is the tremendous work that, because there's 2 things through this that's going to be very unique for Cornwall, and I think we should showcase that. One is what I think is absolute jewel in the crown, having come from another area to Cornwall, which is our voluntary sector and the infrastructure that we've got, and the work that we're going to be doing around the warm hubs, which will be a major component of this. And the second area will be what we're calling our digital urgent front door, which is our single point of access to help ensure that for people that need an alternative to ED, working with SWAST and thinking about those individuals that fall and having a much better response that means that never happens again. That single point of action is a major flag for us in terms of something we're doing uniquely here in Cornwall.
Okay, are we happy that we've done enough on there? We're going to come back to certainly the 6 priorities programme boards. Okay, so let's move on. Thank you. So the next item are the committee chair updates. So we just introduce this bit again. So the papers this month are a bit unusual because they carry terms of reference, which you won't get every time, of course. And the idea is to be compact and bijou, and for me to invite the chairs to note by exception, as opposed to run through their reports. But I think this would be the place going forward, colleagues, where we wouldn't just have the committee chairs update. This would actually be, for example, if we can have these papers from yourself and from Ali and that, again, and I wonder whether, Joe, we should actually have in this section here a paper from the voluntary sector. And I'm going to try in this half an hour to give you the space that you want to here, but I'm just wondering whether we could invite maybe you or Emma going forward to actually do a similar kind of thing, so we get the third sector's input prepped in a proper structured up way. Does that work for you?
Yeah, be very happy to do that.
Yeah, lovely. Okay, so in this instance, I'll do it in the order in which it's in here. So I'm going to run down the order of committee chairs that I've got here in front of me, and then we'll see where we go. So it was, I'll start with Tarn. Could you just walk us through your committees, please?
Yeah, for sure.
Down here.
I'm down there. Yeah, for sure. Let's start off just by saying this: the mood that was taken in from yesterday, I think, was demonstrated also in the Workforce Committee, and there was a really good coming together and a desire to move towards one workforce strategy, and to focus on the recruit, retain, train. I think following on from that, though, to say we didn't quite get some of the approach right on the 75 apprenticeships. I think we've picked that up. I think some of that is issues around stand-up. I think it's about getting some clarity about the governance routeways, and I'm hopeful now that that's going to come back through workforce, and we're all going to understand where we all are with that, and to learn by doing, I think, is the approach we need to take with that. Big ticket item is cost of living. That was a really big thing that came up in workforce, and we are looking at it for workforce, and we need that
to be joined across.
While you've got the floor, anything on remuneration? I know you've got one this afternoon, but anything on...
Nothing
No.
particularly. Joe.
So just pausing on this, because it carries the terms of reference and other stuff. So park for one moment your update. I'm sure we can come back to your update. Is there anything in the detail of the terms of reference here that anyone has an objection to? Because if not, we'll carry that as a happy with on both remuneration and workforce. Yeah. Anything on TARS? Sorry, is it on the terms of reference?
Only because you've asked the question. The paper's asking us to note the terms of reference as set out, and I'm content to do that. But if you're asking a question about do you agree with them, I'd have I guess the same question I raised at an earlier meeting, but I'm mindful the governance is asking to note the decision that's already made, so I'm content to do that.
Can I make a suggestion then? Because we're all in a learning phase. Why don't you pick that up if it's to do with Tarn's area, and then Tarn, you capture this, and then when we have a bit of a wash up in a few months' time, we will come back again and try and capture all these points as we roll and as we learn. Yeah?
So I think the point Steve's making is around my membership of the Remuneration Committee. I agree with Steve. The legal advice we've got is that there isn't an impediment to me being there, but I think as it's been raised twice, I think we would be best to go with a board feeling around whether it's right for me to be there or not, rather than a legal view that it could be okay.
Okay, so let's not deal with it now. But I mean, clearly, the non-execs, the only time that would happen is when the non-execs issues are coming up, and it seems inappropriate for the non-execs to do it for themselves. So we need somebody, and that's really what was behind it, to do it. But feed that into Tarn, and we will do that. Okay, so Tarn, are you happy with that? Can we move on?
Yeah, sure.
Right, so let's move on to Sanj.
Thanks, Chair. Yeah, just a few key updates, I think, from the Finance Performance Commissioning Committee. Firstly, to say that we received the 100-day plan update from Rachel, and I think we've noted that in some areas we've seen uneven progress, particularly 30-day handover. So it was really good to see the plan that Steve shared, and we've all agreed in terms of addressing that. And what I see is what is most urgent is, almost 60 days into that 100-day plan, that we have a succession going into the winter. So I think that point's well taken and noted. I think the biggest internal piece for the committee was the reporting format on performance and commissioning and finance. And we've agreed to use a new template going forward in subsequent FPCC meetings, and therefore affecting the reporting to the ICB, which is much more streamlined, was included in part 2, so that is the format. It will be adapted to include distinct reporting for the ICB and the system, so that is the only variation from what's in part 2 as a template. And we're going to be working with that going forward, and I'll be meeting with the relevant execs between now and the FPCC to ensure that happens. And lastly, the only other key thing to note is that the National Oversight Framework has been obviously shared and circulated, and a really heroic effort by the team to get the reporting to where it is in terms of what we can measure, but there are significant metrics that neither at a national level or at the ICB level across the system we know how to measure, or whether we are certain is being collected locally. So there is some work to be done, and I think we just need to be realistic on the timeline to achieving full reporting against the National Oversight Framework, to John's point about other priorities, particularly coming up into winter. So that has been noted. The action, I think, for the committee is to come back to you with a realistic timeline as to when we will see full reporting against the National Oversight Framework alongside other priorities, which may well, to put it on the agenda, be into 2023 before we are able to do that.
Thank you. So again, let's chunk it up into 2 halves. We're noting the terms of reference. Thank you for phrasing it, helping me phrase it that way. Any thoughts anyone's got, feed into Sanj as we go forward. This is on terms of reference. Yeah. So what I'm going to do is note the terms of reference in this instance, and now please comment on what Tal said.
Sorry. So I just wanted to be absolutely clear on those that we're not reporting on. It's because we don't have national data feeds that we can pull on. They aren't pulled through as standard reports from our providers or from any parts of the sector. So we are somewhat reliant on those being fixed nationally, because some of them actually are even how they're measured. So it's the quantification of those, so we get that consistent. So we are keeping an open dialogue with NHS. There is going to be an integrated performance report that will be developed by the centre, which will improve that. We are chasing a timeline for that. It was due in September, and we're working very closely with Calvin as our digital and BI lead to help support our access to that integrated performance framework.
Sense, do correct me if I'm wrong, from what I've seen of it, is that it's moving on from, what should we just say, traditionally has been looking at year to date, and recognising you do need to look at year to date, but it's as much now looking towards trajectory, and have we got confidence in plans in trajectory such that the scrutiny committees can do what scrutiny does. To actually sort of how we're doing, and that's not just about money, but that's actually about performance as well.
Yeah, it's the ability to reforecast not just budgets but also performance targets as well. So it's the same principle, and I think the new template allows us to do that. And if there are changes, then they can be reported through the committee to this board.
Very good. Okay, thank you. So let's move on to Martin.
Thanks, John. Audit Committee 2 meetings in August. First one was a standard meeting, if you like, where we adopted the audit plan, reviewed early views of the risk registers, and had some discussion around how the committee is going to work going forwards. And it's probably fair to say at the moment, it's fairly internal, CCG-based, traditional style audit committee, but we have some meetings coming up with the chairs of the other audit committees in the patch just to try and see whether we can share best practice, how we can do system audits differently, or if there's anything we need to do slightly differently in the new world. Similarly with the risk profile, so how do we as a board set up our board assurance framework to both understand internal CCG type risk and external system risk, and how we get visibility and mitigation of that. So doing that piece of work. Second one was a special meeting just to, not to approve the accounts of the old CCG, but to receive the audit report of the accounts of the old CCG. CCG board had delegated, to the chief exec to sign those accounts off, but we still need to receive the audit report. Basically some good news in there, good working papers, unqualified opinion on the main accounts, a qualified regularity opinion on the accounts though, because there were, I think, 3 payments that had been, prior approval should have been sought but wasn't, so there's a slight issue there, but those accounts are now ready to be signed. Unfortunately, there's still another set of CCG accounts to come, which are the April, May and June ones, which I suspect will have to come to this board, unfortunately, for ultimate sign-off, but still being created. So those are the 2 meetings.
Thank you. Again, let's break it into 2 halves. We're going to note the terms of reference and say we've noted that, unless anyone's got a violent objection to that, we should be straightforward. Okay. Any comments on Martin's commentary? Any questions? Sam?
I just wanted to add, for clarity, for the CCG's annual, the 12 months accounts, we still await the final audit opinion. So there is a refinement in that they're concluding. We expect to receive that within the next 2 weeks. Just to add that. Thank you.
Simon, I've forgotten there was a value for money bit, wasn't there?
That's
Still to be
fine.
finalised. Yeah.
Good point. Thank you.
Sorry, John, very ignorant question. Is that at our trust, all of that gets reported to our annual public meeting. Is there a sort of parallel of that for the ICB, or is this what we are?
When I saw for the first time what you did, that's exactly, I was going to pick that up with Kate and with Trudy, so I don't know yet, but I don't know what I don't know, but maybe we should, so should we take that offline? And
There's no reason why we can't do one, just because we've not formally asked to, doesn't mean to say that we shouldn't.
Yeah, so we'll take that. Thank you for that challenge. We'll take
And actually, if we begin to, and not for this year, maybe we do them all together. So it's a bit more of an interesting Cornwall and the Isles of Scilly annual public meeting jamboree, because it can be a nice celebratory thing as well. It's actually, this is what we've been doing, and here's our accountability.
That's a good idea, because I'd like to, we were talking about making our next AGM, not this the one that's coming up this month, but next year this time, a bit of a celebration, a fate.
Are we collectively up for that?
Yeah.
Because what I noticed was the celebratory moment.
Yeah, that's what we would like to do.
A lot of this is about trouble and what, that's, so I think that's a collective correct and trouble.
Pete has made an absolutely brilliant video that we're going to be playing as ever, so we could make it an inclusive one. Sorry, Pete,
the superstar.
Is it on TikTok?
Oh, don't, because he will do one on TikTok if you want him to.
I don't do TikTok, so I wouldn't even know. I don't do Facebook either, so I wouldn't know that either. Okay, so moving on. Thank you, Martin. Happy with that? Thank you. So, Carol. No, just go, Carol.
Oh, just goes. Oh, good. Thank you, Chair. So the first committee that I'm chairing is the Quality and Pathways of Care. We've had one meeting and since the ICB started. I'll take the paper as read. The paper is asking the board to note 2 items. One which was a verbal feedback about the Quality Risk Summit, which covered ambulance handovers and the 100-day challenge. And then secondly, an excellent patient safety incident investigation report commissioned by CIOS, which we have signed off. Importantly for the committee, in that report there are recommendations for ICB, so it's really important that we don't just note those reports which are retrospective, that we do something about the recommendations in there, and that is, I've been reassured, is going through SEG. So and importantly for the ICB, our recommendations will go through the 100-day challenge, will be fed into the 100-day challenge, so that's really important. Just picking up, so there wasn't really, there was a couple of other items, but those are the 2 items I wanted to bring here to the board. Just wanted to pick up on San's point. The Quality Committee is working with Finance and Performance on the reporting mechanism. It's really important that, and I know that the exec team are on board with this, is that it's not CCG related. This has to be something looking forward. And so, as San just said, it's 3 things really. It's the, making sure we've got the statutory items covered, making sure we've got measures, performance and progress we expect, and then year to date and trends and looking forward. And I suppose I'll share my slight concern with everything that we've talked about today, that we have talked about an agenda to get that sorted for October. And I appreciate from the execs team, that's a really tough ask. Currently, we've got a quality report coming up, which is completely almost separate to the committee. And what we're trying to do is integrate it. And I know there's lots of nods and the exec team will be on board with that, but I do just want to set it out that I think that's a really tough ask for you guys to do. Also, it's very timely. So the stuff that we've done doesn't seem to be really in sync with where we are now. And that's why the looking forward is really important, because by the time we get to this board and we've had our committee, we'll be able to give an update to say, well, we said we'd be here by now, are we? So that's why it's really, otherwise the committees are just a reporting in mechanism and they're not live enough. So
keep the floor for a second and talk about your second committee.
Yeah. So the second one is the Citizen Engagement and Equalities Committee. Just trying to find the paper. Regrettably, we have not met yet, which in light of where we are, thank you, Mayor, in light of where we are is a real shame actually, because we do need to keep our public informed, on board, instructed in what we want them to do. So unfortunately we've not met yet. We're meeting in a couple of weeks' time, and we are hoping to appoint a Director of Engagement. I might ask Carolyn if she wants to give us an update on that. But what I have set out there is the first meeting's terms of reference. And I think just the other thing I'd like to say for both the committees is that I want the committees to be as inclusive as possible. So the terms of reference stipulate key members of staff that need to be on there. I want assurance from the exec team of the ICB that they have buy-in from all the other providers and all the other partners. We all don't want to be going to 10 meetings, but I do want to be assured by the exec team that they have spoken to partners. And if partners wish to tune in, we're going to do some of them face-to-face. That's really helpful, and I really value that. This can't be done in isolation and in a bubble, and particularly around citizen engagement.
Very good. So let's deal with terms of reference first. So again, we're noting both. No violent objections. Everybody happy with that? Okay, so let's deal in some sort of order. So any observations on the commentary from Carol on quality? Susan, just go for it. Yeah.
Just that I would agree with Carol. I think the quality paper that I'm about to present is not where it needs to be. I think there's an awful lot of duplication. And I think we do need to make sure that we are really clear on the priorities that we've agreed today and what are the quality and safety concerns or improvements that are wrapped around that, but ensuring that the ICAs are also feeding into this from their quality and safety, and I don't think we've got that right. So I completely agree with you, Carol. There's an awful lot of streamlining that we need to do.
Carol's point, because it's on the back of Sandra's as well and others. Historically, it's not a criticism, it's just where we're at. Historically, it's been a lot of year-to-date reporting. And what the team can add value to is to actually look at what the executive thoughts are looking forward and to support you all in terms of that's what you said you'd do by X date and how do we make sure we're supporting you and the team are doing that to do that. So it's not trying to catch you out, it's trying to support, but we need those metrics.
I think one of the things that we're struggling with, and I'm going to look at my directors while I say it, just if anybody rolls their eyes, is that we are working with a group of people who prepare papers, but they're not necessarily preparing them for the committees in their current form. So we need to debrief and rebrief our teams around how we want them to work going forwards, and the primacy of place underpinning what we're doing and being able to track, you know, improvement, harm, risk, delivery over our places, and so that it can be reflected through our core committees as well as our place-based committee. I think it will be a challenge that we'll get better at, but we're definitely not there yet.
Thank you. Let's move on to any observations on the citizen engagement one. Did you want to give an update, Karen?
Just picking up on Carol's point about the Director of Engagement and Comms, there was interviews on Tuesday. We have put an offer out to an individual, obviously awaiting, they have verbally accepted, obviously we'll be awaiting references, etc. to come back, but I think it's going to be a good appointment.
Very good. Okay, thank you. So let's move on. Neil.
Thank you, Chair. The ICA committees have been meeting. We've had 3 so far, the last of which was 2 days ago, so there are elements of a verbal report in this. My report was based very much on the first couple of meetings we've had. Very grateful for the input that the managing directors have had in terms of bringing together the ICA teams. I just want to reference you to a couple of key points on page 1 under next steps. I think whilst we hear about getting involved in the here and now and the winter plan, the sustainability of what we all want to do going forward, if we're basing that on place, needs to be that we are future focused in our strategic approach around developing place, and that's why I've identified and I've written an urgent need to identify place-based services that need underpinning and improving, so that we can look towards informing ICA budgetary requirements going forward into 23-24 and beyond, if that is our premise that we're moving forward towards place. And I also, under next steps, just wanted to draw your attention to the fact that whilst there is a lot of involvement in activity, we do need to see clear frameworks and metrics start to emerge around the services and place-based activity we're going to achieve, so that we can account for the shift in resources that's needed. And I think that's a shared approach that we need colleagues across the system to be involved in, and we welcome the fact that at the last meeting we had input from RCHT partners, and we will have input from CFT partner from meetings going forward. This will allow information flow to and from the ICA committee back to partner organisations, and I think in time we need to reflect that through the VSF as well. And it will also allow, at the point where things need to move quickly, unblocking and enabling of things that we need to make work that are brought together by ICA forums and teams. You'll note that in my comments at the end, with regard to the links with PRISM and the previous organisational and corporate knowledge we have, we do need to concentrate on strategic plans now, because the here and now we can do together, as we've illustrated in this meeting today. The future, if we're going to build it properly, we need to start planning for. Primary Care Commissioning Committee is a long-established committee. I just want to draw your attention to 2 issues within this paper, and there's been 1 meeting so far. GPIT systems, I mention it because the need for joined up IT and joined up ability for one record for patients, which is something that many people plea for, so they're not asked many times their story, to some extent is underpinned by the need for GP practices in Cornwall to sign up to the Devon and Cornwall Care record. I believe my figure of 54% is now superseded to around 66%, but as this underpins future working in IT development, it's an important part of a challenge for general practice to work on, and we will be looking to monitor that. I think it's clear that one of the big challenges for PCCC is pharmacy, optometry and dental delegation, and the next meeting we're holding in next week will focus a deep dive on that particular issue. I also made it clear that the primary care terms of reference for that committee have been altered to reflect the fact that primary care is now linked, particularly with its links to primary and community care, to underpinning the priorities for the ICB and ICS going forward, and there is a need to account for their involvement in work that is needed to deliver against all the priorities and the ways we're going to work. And I think it's important through Primary Care Committee that we communicate some of the development that we've already been talking about today back to primary care. I don't know if you've any comments, Rachel, to add to what I said.
No, I think that's right, and I think it's really important that the next meeting is a deep dive on those future delegations, because I think we've got two component parts, just to be really clear. One is that we are preparing this year for the due diligence that we need to do in terms of taking those on, and secondly that we're involved ourselves and across the South West on the options for actually how we would deliver those delegations for optometry, dentistry, for example. So I think that's a really critical point, and thank you to the team's leadership on the work they've done so far in thinking that through.
We finish this item. Two things. Can we just talk about then the terms of reference? So on both committees, I take it we're just noting and no violent objections there. Good, just for good form. Thank you very much, Trudy. So let's just now break this into two bits. Let's talk about your ICA observations. Anything that anyone would like to raise there? I've got one, but I'll let everybody else go first. Mary?
Sorry, John, it's not a specific content observation. It's just to say I really like the layout of this report. I like that concept of activity, next steps, activity, next step. I think that's really focused, and I really like the sort of chair's remarks piece at the end as well. So thank you for that.
All learning, I think that's possibly we could take into other committee updates as well. Any other thoughts? No. So did you want to add anything, Andy?
I suppose I ought to say something, given it's my area of interest, but I think it's to thank Neil for some fairly firm comments in ICA committee report. I like the format very much, and really there's a question about next steps. There's a really clear statement here that Neil has said on behalf of the committee, and clearly as an ICA managing director I feel those comments, and we need to work on the next steps and the strategy going forward. We are learning to work at pace, and we need to learn and work faster.
I'm particularly taken by the paragraph where it's asking the three managing directors to concentrate on strategic plans. So it can't be business as usual every day for the three of you between now and Christmas. So. Okay, so let's move on. If there are other comments on the ICAs, let's move on to primary care. Did you want to comment on that one?
Yeah, there's just two things I'd like to say. One is that myself and Emma, LMC Emma, yeah, Ridgewell Howard met with the CQC to talk about the way in which the CQC reviews had taken place of our 15 practices that were reviewed as part of the urgent and emergency care pathway. The CQC is going to take back to their expert reviewers some of the way people felt about the review, but the CQC were really clear that out of 15 practices only 2 had their rating changed, and that we've got really good general practice in Cornwall and the Isles of Scilly, and I think that's something we just need to hold. We have got really good general practice in Cornwall and the Isles of Scilly, and we need to let our residents know that. The second was around Teresa Coffey's ABCD, and I think we can expect quite a lot of focus on dentistry. We aren't the commissioners of dentistry yet, but I think Rachel, through work with Andrew Abbott, we need to start engaging quickly with NHS-INE around what the focus on dentistry might actually mean for us. So we'll get on the front foot with that.
Very good. Okay, so let's move on, colleagues. So that's the that would have been the half an hour, but Joe, can I invite you, please, from the third sector? You wanted to give a little update.
Yes, just to provide some specifics around the conversation that we had yesterday, and what the sector's kind of ready and prepared to do. One of the things, just to say that we have stood up our strategic and thematic alliances, and that really is an easy and effective place to engage with senior leaders across the voluntary sector. So it's an invitation really that if your team's officers have a need to get a group in the voluntary sector together, that's a place where you can engage with those leaders. For the purposes of planning for winter, we're standing back up Vera, which has senior execs from some of the larger organisations, and we're ready to contribute capacity to the coordination centre. If there's ever a requirement around that for 24 hours, you might need to think about resourcing that, but we need to be providing consistent and senior leadership to support that. We're working on standing up the 34 warm hubs in October, and that will be part of our community hub network, and specifically looking to deliver against some of the system priorities around supporting anticipatory care, personalised care, assisting discharge, activities that are around reducing health inequalities and an impact on GP services. If we take Volunteer Cornwall alone, we've stood up and mobilised 2,000 volunteers who are out there and ready to assist and support vulnerable residents, irrespective of what their vulnerability is. And we're working on establishing how we grow that, but effectively that's 2,000 people, local people as part of the workforce to support this work. So just to let you know that's where we are in terms of our response at this point.
Well, you know me, Joe, once I've heard something, I'd always like a bit more. So I'm just thinking, mulling over the discussions we've had around the coordination centre, but also around access at our front doors, because we don't just have one, do we? We've got ED, but we've also got the CATUs, the Community Assessment and Treatment Units, and the minor injury units. So it would be great if we could, one of the things we could ask the coordination centre to do, now we've decided we're going to have one, is how we map workforce to need based on ambulance conveyance and also what we know around our front doors, because then we can deploy the resources, of which we are seemingly getting more and more, in the right places. So I'd just like to make that as an ask to come back through our winter plan to the next meeting.
John, can I?
Yes.
Just a really quick one. The community hubs that we're talking about, the warm hubs and the community hubs, are these physical places?
So they're definitely concepts, and some are physical places. Effectively, it's place where we're able to bring the voluntary sector together around activities. So.
Is there room to do other things there? Talking about. Is there room to? This is top. It's really on my. I'm sorry, but the reason I couldn't come yesterday was I was with our mental health transformation and PCNs, talking about pushing our services into the community. And one of the big things that comes up is there's no space, but there are spaces in various third sector. And how do we coordinate that so that they're appropriate for the services that we provide, but they're close to where people live and are less threatening, perhaps, using those terms? So I just wonder if there's some way we can start joining all of this together.
So I think if you pose the question, we'll take that back to the Alliance and come back with what we think we can do.
So if Claire Fuller, who wrote the Integrating Primary Care Neighbourhood Teams, I haven't quite got the title of the publication right, but if she was here, she'd say, why do you need a statutory sector and building to meet in? Go to church halls, community centres, go to cafes, go to places where people are, libraries. So I think we need to be much more imaginative around how we use physical infrastructure. We don't need to own it. We can buy tea and buns anywhere.
That's exactly what I keep saying to all of my teams.
And that's such an
What's
important
wrong
observation.
with the village hall?
Rachel? Final comment from Rachel.
Short comment about the cost of living work. It's not only the warm banks, which are a new concept, but it's the whole of the community response. And the event on Monday was about drawing together the work in the community that includes things like how we can make sure people's incomes are maximised. There might be the use of credit unions as a real promotion of pension credits, all of the things that are going on sort of in addition to that, and particularly the role of food banks and ensuring that people can keep warm in their own homes, as well as if they may be able to visit somewhere. So I just think I wanted to just make reference to the huge amount of work that community leaders, the voluntary sector, the statutory sector have all done to bring that together, and that's going to be a sort of intense community bit of work, which I think underpins the winter response that services will be picking up through the winter, that we need to see that whole picture of a joined up place-based bit of work.
Okay, thank you.
John, could I just add one very small challenge to Joe? And you might already be doing this, Joe, but the piece of work that started in Newcastle has now actually expanded to citizens offering a couple of hours in the warmth of their own home. And given what we were saying yesterday, about, you know, all our risk antennae will go up if we say things like that. Well, okay, let them. Because actually the concept was, and I think it's a good one, if we've got our sitting room heated and somebody wants to sit in it for a couple of hours, keeping all the respect and dignity that we can, I think small communities would do that. And I just wonder whether that's something you've entertained.
I don't think we have specifically, but Ali was referring yesterday to the shared lives work, which is about how citizens might open up their homes to people who have needs. I don't think it was necessarily about sitting in a warm living room for a few hours, but I don't see why that couldn't that scope.
Is it 31 or 34?
It's 31.
Forward, Joe.
I'm just a numbers person.
You know me, I never write anything down.
My sentences are rubbish, but my numbers are pretty good. Okay, cool. So let's move on, everyone. Thank you ever so much. Now, the next section, I think there's an element here. Please take the papers as read, because we've got 25 minutes on this. These are important topics. But I think we're already recognising that they're not necessarily fit for purpose. So we could spend a lot of time chatting over them, or some of them maybe not all of them. And I won't say which ones I think are better than the others. But I think there's an element here of we must have the discipline of going through quality performance and finance each time. The question is, are we going to get great value? I think, yes, by touching on it, but I'm actually now, particularly after yesterday and the way today's gone, I'd like to spend a little bit more time chatting on the transforming care for Cornwall and getting agreement maybe around some of that, and that might take more than 15 minutes. So we have 25 minutes on this particular section for the 3 papers. So I'm going to just look now to the order of quality, then performance, and then finance, and lay down the challenge to do what you need to do, but as quickly as possible, please. So who's going first on quality? Thank you, Susan.
So I won't rehearse many of the conversations that we've already had, but there's still quite an awful lot of work that needs to be done around the quality paper, which Carol and I will be working through. I would, however, like to point out that the areas we have covered in the quality paper, and I'll take it as read, are those that are driving some of our crude mortality, so it's important to highlight. And I was reminded last week in London by Centre that throughout winter we cannot lose focus on quality and safety, and whilst some of the decisions we have to make as an ICS and ICP will be difficult and at times unpalatable, we need to maintain quality and safety at the heart of everything we do, which brings me on to, if we're talking about forward-looking, the dynamic risk assessments that we've all signed up to and the dynamic MDTs, multidisciplinary teams, ward rounds that we're doing throughout RCHT and CFT are incredibly important in drawing out those very clear quality and safety issues that will help to create flow within our system, which is important. If you look at the statistics, only a third of people are getting to the stroke unit having had a stroke. That's if they haven't already had a very long wait on the back of an ambulance. So in terms of morbidity and mortality, that's quite a stark and depressing statistic that I think we all need to be minded of. Whilst our fractured neck of femur fares slightly better, it's still at 50%. And we know that the long-term outcomes for people who have fractured neck of femurs, which in the main tends to be our elderly population, are not good if you haven't got to theatre within 36 hours. So the national standards, we are not anywhere near at the moment, Chair, which is why they have been highlighted. And we see ourselves in Cornwall as well, for the first time in quite some time, starting to, I won't say fail, but we're starting to see a decreasing picture on our cancer standards, which in the main has been largely driven by our inability or around diagnostics, conversations that I'm having with our executive triumvirates. Forward-looking, however, I would like to report that we have been shortlisted, and it speaks to the section that we've done on citizen engagement. So we've been shortlisted for a national project where we will be giving some funding about how we engage our patients. And when I say patients, that's all of us, because we're all potential patients, and how we use that to commission. So one of the things that we're looking at is how do we commission on patient outcomes? Which I think is turning our commissioning and the way we've done it in the past slightly on its head, and quite exciting. And that would sit really nicely and sit well with any of our citizen engagement in the wider piece that we've been talking about originally. So there's more work to be done on the quality paper, and I'm hoping that we can engage our quality leads within the ICA to make sure that we are addressing our place, the pledge that we've made as an ICB, to hearing voices at a very granular level.
Very good, thank you. Any questions on the paper or charges?
Just really briefly, and it might be one to consider, how do we, going forward, have a quality paper that reflects the integrated care systems? So what are our mechanisms to have a quality assessment of the provision of domiciliary care, residential care, and the wider health aspects? And I think you're indicating in the opening comments there are potentially some themes across all three papers, but it's a very clear summary of some aspects of health quality, but not the wider system.
So now you can speak for yourself, but I'm going to try and put a more view across the three papers here. So please don't anyone take offence by what I'm about to say, because I can easily do that with what I'm about to say. There's something about ownership at this level, by who writes these papers, and taking the point you made earlier on, there's people who actually write these papers who have not heard any of this, not been engaged in any of this, don't see any of that. So with respect, I think there's something for me about, actually I'd like to see the authors actually as your directors. I mean, the fact others might do it, but I'd like to see some ownership of these papers, because if not, your team just apologise for other people writing it, and that doesn't feel appropriate at this level. That's harsh, but I hope is a comment that my colleagues have made to me, so I thought I'd pass that on. The other one is something that Steve's picked up on, which is at what level is this narrow and at what point is this broad? And that's why we need your colleagues to sit with our colleagues here and almost sit in a darkened room for a couple of hours and just say, what are these reports going to look like at high level? What is it that you want to share with us and that colleagues here want to scrutinise and come to here? I think that's a piece of work that's got to be done. And just the statement again, these are looking backwards. This is a year-to-date report, and although that's interesting, I think there is something here about saying, thank you, we need to know that.
So what's the next step?
But what next? And I think that's why in Neil's report, when he actually started to sort of unpack these are we're at, but here's the next steps, as we can learn from each other. I think when I read these again, I thought there was something, Neil, really in yours. I'm not trying to have anybody. I think it was really in yours that if we're all going to learn from each other. I thought that was really good stuff. So that was because we had an hour together as a group of non-execs this morning as well. So you wanted to comment?
Yeah, can I just make two points? One's around boiling the ocean. So as soon as we move away from constitutional standards, which these are, then we'll be in the areas of safeguarding, inequalities, equity, fuel poverty, generic poverty. So outcomes for social care, I think, are somewhat harder to measure than time to theatre for fractured neck of femur. So I would like to have Ali in the room to work out how we would measure that, because I'm not sure where we'd start at this point. And then my second bit is the best old-fashioned NHS manager, the best indicator of future performance is past performance. And one of the things we need to pick up across a range of our services is that we are failing in achieving the constitutional standards we've been set, whether it's the ambulance service, whether it's neck of femurs, whether it's community mental health assessments. It's across the patch. So I think this is where the prison work starts kicking in, health checks. It's where the prison work starts kicking in. What do we need to do that's within our control to be able to start pulling some of this round? Because I'd hate us to leave the quality report, even though it's not good enough, without logging the fact that, even the stroke metrics, the one that bothers me the most is time to CT scan, because if you don't get scanned within the hour, then treatment doesn't commence, and that is, whether you run a stroke unit or not, that does improve outcomes, but there are some metrics in here we need to pull out as the ones that really bother us, and then they're the ones I'd want to know, now what? And then I think it makes it easier for all of our providers, because this is RCHT in here at the moment, but if we looked at UHP, we'd see a very, very similar distribution of risk and harm. And for us as a board, what we're going to do about it would be somewhere I'd like to be. So I'll take away the social care, because I think we can do performance. It's the quality impact that, so we'd be having to be looking at reablement and safeguarding referrals and those sorts of things.
So I think the opportunity here is not to look back and criticise this.
I'm not being
No. I think I may have been, which is why I'm trying to kind of not trying to criticise what has gone on. But isn't this an opportunity to say that would have been great for the previous colleagues who looked at it, but this is a different cohort of people that might need to look at different levers that are collective, and how therefore do the quality, because we'll end up doing RCHT's role if we're not careful, or CFTs, and that's not our bag. So Rachel, you've been patiently waiting.
Thank you. I mean, I think I agree to some extent with Steve around bringing in a wider range of quality performance. There are a whole range of other people who are joining the quality committee that deliver clinical services. We've mentioned this before. It isn't just through the ICB commissioning, and I think doing system working, that's what we're doing different. So not throwing, like trying to boil the whole ocean, as you say, Kate, but picking up some key indicators, which I'm sure is the intention, so support that. And I'm sure Ali would if she was here speaking on her behalf. And then I wanted to just share just a quick update on the CQC report for community children's health services for early year, which I don't think was published. It was published on the 1st of September, so not in time for this report. But the CQC was a good rating across all domains. So that's just wanted to share that positive news around that. Health visiting and school nursing.
Noted. Thank you. Mary?
Yeah, very small point, but happy to take it offline. But I did put in an ISO 9000 quality measure for how to have a quality bath in a residential home. And actually, we then extended it to other types of social care. You can do it, and the best people to do it are the people who are actually doing it. Tell us about it, who are having the bath. So I'm happy to talk to you about that, because those things, ISO standards do exist for social care.
So move on. I think you'll have everyone's support in radically revisiting this, recognising this is why we're all here. Really. Forget the governance, forget the money for a second. This is actually, in some ways, why we're here. So what is it that you would like to see in the report that would actually help all of us? And we're not going to get it right again next month, but I think if we get the direction of travel right.
Yeah, John, could we get some health inequality measures in the quality report too? Because I feel that that's lacking.
So, thank you. Can we pick that up under performance?
Well, is it performance or is it quality? I get confused, because in some sense, some of this is performance.
No, I agree.
Yeah, there are quality aspects to it, but 36 hours to surgery is a performance.
Let's have like a Venn diagram, a bit of an overlap on the two papers for a moment. Kate, could I ask you about, I'm going to approach this slightly differently. How do we get the evidence about population health? How do we get the evidence about the drivers behind here? How do we have one set of BI? What are your thoughts in terms of how we do that? Because if not, we'll end up competing with my version of the truth says this, your version of truth says that. So how do we get to one place? Because that's both performance and quality. That's what I'm trying.
So I've started a conversation at the System Executive Group around how we'd have a single director for digital BI and population health metrics, acknowledging that Rachel's department would need to co-own quite a lot of that, because it links into the core responsibilities of the Director of Public Health. So it's how that function would come together. Debbie has asked me to bring a job description to our next strategic seg, which I think is in a week. So I'll bring a job description from Northumbria. Or Cumbria, I can't remember which side of the Pennines it is, to the SEG next week. We do need a single version of the truth. When it comes to quality, one of the things I just want to pick up is that some things are proxy metrics that we use as indications of quality, because we know that there's the mortality gradient that sits underneath it. Time to theatre for fractured neck of femur, time to scan for strokes. They are all proxy measures that we can measure, knowing that they link into crude mortality. So I think there would be something, if we could have a glossary that might be helpful to get us all into the same space around why we're using certain metrics. If Rachel and I pick up offline how we look at the inequalities broadly, but also a dashboard, so that probably doing it monthly won't be helpful, but maybe quarterly impact on certain things, because we should see some directions of travel potentially. But the our annual DPH report and the Joint Strategic Needs Assessment is our compass, isn't it? It's the thing that drives us.
Okay, has that been helpful on that one? Shall we move on to... Are you happy with that, Margaret?
Can I suggest that Carol joins the discussion with Rachel, Susan, Helen and I. And Mary, can we nick some of your time? Because I'd be really interested to get some, proxy measures for social care, and it would be great.
I'm sure Ali will have some of that as well, though.
Thank you. Performance.
Thank you, Chair. I'm not going to repeat the conversation around performance we've had around our urgent and emergency care. And that's not for me thinking that isn't of a concern, not one to give assurance, but I think we have discussed that, so we'll pick that up in questions. But I did want to spend some time talking to the board around the deterioration that we've seen for a second month now in some of our areas of elective care and cancer. And I think this is important to hold for a moment, because we have predominantly as a system been in a better place in terms of our elective care and cancer, and this is significant for us and the people that we serve. We start to see in that planned care space that deterioration and the impact in terms of a picture of the things that we're improving or not. So I just ask colleagues to hold that. So in particular in terms of our 104-week wait, so the target for that was 0 within July. We breached that by 14, which we reported last time. What we do have assurance of is that there are plans during August and September for those patients to be completed and seen. So we recover the position over that period and have been talking with our clinical colleagues and our regulators about that position. The UHP position is still a significant number, and that's reliant on mutual aid across systems to help support that. And again, we are both supporting where we can on that, but also working with our colleagues in Devon in terms of the overall recovery plan for 104. In terms of 78 weeks, we remain on track. You will see in the pack there is the trajectories. Those plans were based on what we submitted and we collectively signed off as a system as part of our operating plan. The areas, however, where we are seeing deterioration is 52 weeks and diagnostics. And there's a golden thread through both our cancer performance and our RTT in terms of the impact that diagnostics is having on the overall pathway. To provide assurance to the board, we are working with our providers and have requested a formal recovery plan for how we bring back that position. And that, John, we will be able to then see in terms of that forward plan in that reprofiling of those charts that show the updated position, and the actions at the end of the paper talk through some of the things that we are taking forward as part of the next steps. Particularly in cancer, our concern is around breast. We've seen an increase in the numbers against the profile that we saw, but predominantly this is around our diagnostic and our radiology capacity. And diagnostics, we know that would be much improved when we have our CDC and our extra CT. A lot of the contributing factors there were with regards to downtime that we had and the fact that unlike other systems like UHP, you can see their performance is much better. They've been able to access the mobile diagnostic support, and that is one area that we are working with the Trust to see how we can secure that with regional support. Lots of that is based on where we can actually put that as a facility, but we are actively working through that. The other area that I would just bring the board's attention to is particularly with regards to mental health and learning disability. We continue with our treatment and care reviews to ensure that we do our very most to make sure that we support people out of inpatient settings and back into the community. It is very challenging in terms of finding the most appropriate place and placement for those individuals, but regularly with our treatment and care reviews, ensuring that we do that and that we as swiftly as possible, but that reflects a national picture with some of the challenges there. And secondly, in terms of our IAPT access, we remain underperforming performing against our target. You can see there the June datas that we fell below. We are working to review those trajectories and some of the recovery plans. It is challenging in that particular area and reflects again the national picture, but the work of the mental health teams and the programme board is focused on the actions there, and that's a combination of workforce as well as the activity profile in terms of being able to recover that position. So what I would be expecting through FMP next time is that we see the output of those recovery plans to be able to recast then that trajectory to bring us back online. It's really important, not just for the outcomes of the individuals, but for our role as a board, that we bring particularly those areas of performance back on track.
Thanks, John. Yeah, I nearly asked this in the 100-day plan section earlier, which was, it did occur to me, to ask really, when we're focusing on flow, obviously flow should help, the A should help the B, let's say, ambulance hold should help backlog once we get the flow working. But I was wondering whether there was a slight risk of putting so much into the A that the B started to worsen. And, I suppose the question is it the case then that I'm right that once we get flow right, we should help with backlog and elective work? Or is there a danger that we're putting all our eggs into, the ambulance holds, putting too much of our capacity into, urgent and emergency care, and then losing some focus on the backlog? Or is there a sort of synergy, a sweet spot where our plans will help both?
So we certainly monitor our cancelled surgeries, and there's been very few that have been notified through certainly the daily sit reps on that case, and we're doing our very best on our tactical calls to avoid that position. But for some of these pathways, they're separate to that flow issue. If you think about some of the outpatients and the diagnostic work. So I think there is something about ensuring we've got the right capacity of all of our focus on both urgent care and planned care in terms of operational delivery, Martin. But as you see in the action, some of those things are related to things that are external to flow and in hospital stay.
So we know that there's going to be a national data set, so they're creating a single data warehouse for finance and performance. And we the portal's open. We're going to register. So for our IPR for finance and performance, it will come from that national flow, so that we are looking at the data that they're looking at nationally. And alongside that are some accepted norms, like 80% of RTT is non-bedded. So for those non-bedded pathways, we wouldn't expect flow to interrupt them. So we just need to start getting the things that we know that our region's using to hold us to account. There's a local discussion to be had on weighted activity units, which is how they're measuring efficiency and productivity nationally with RCHT and UHP, because there isn't necessarily an agreement to WOWs being the best way of doing it. But as a finance and performance committee, we need to understand it. And then when we're here, we almost again need that glossary around what this means so that we all understand it.
Thank you. My personal view from a ambulance performance perspective, particularly in terms of Cat 2 responses, is the single greatest factor that influences it is the number of acute hospital beds occupied by patients fit for discharge. So others might disagree, but that would be my view. It is critically urgent, I think, for this board to have sight of that kind of performance information, and I recognise that it will take us some time to develop a system-wide performance report, but I do think there are some performance measures and reporting that we could have very, very quickly that would start to give us some of that. So Rachel, if we could see that develop really quickly, I think that would be useful for all of us as a board to be able to progress.
I feel confident if we're going to report against the specific priorities that Steve and the board have outlined here, that that's a good basis on which to track performance and improvement. I think the 100-day plan has highlighted that some of the things we have been doing haven't shifted the needle on the key metrics. So the shift to these key 5 priorities, and particularly Steve's highlighting of beds and patients suitable for discharge, if that's the metric, we will measure and report against it. I think the bit that we are committing to, I think, Rachel, is what is the target we are going for, to Mario's point, and therefore are we on track? It's not just coming down, but it's coming down per the plan. And that's critical coming into the winter. So one of the challenges.
got a place that you're at, and you just say, I'm at 60%, we need to get to 80. Just putting on a chart 80 that isn't the, I know you know this, isn't the answer. And in the scrutiny committees, they need to know the actions that will be taken in each month, measured by what you think you can achieve as a group, so that we can actually say, yes, we're doing it, or we're not, which is why it comes down to the few metrics that we all buy into, but we've actually got that evidence. Because if not, it feels like we haven't got the evidence based on what are the levers that are making a difference, and it becomes a game of chance if you're not careful. So let's base it on evidence.
So two comments to come back on. So that's exactly with our recovery plans, the information with our providers that we work through in terms of the actions and the impact to reset the impact that will make. We've also still got the conversations with our colleagues around our elective recovery fund investment, and as those are agreed and embedded, the impact that will have in contributing to recovery. I just wanted to come back on the ambulance trajectory. So when we did that and worked that through SEG, there were three main factors that contributed towards the days where we had the reduced in holds will. That was 0 DTAs over 12 hours, reduced length of stay, and we were hitting across both P0, P1, P2, P3 targets, and that was consistently of 137 discharges. So it's a number of things that contribute towards that was, and one of the pieces of work we agreed with Steve and the UEC board to do, which is where we hold some of that granularity of detail that Steve was describing, was actually to continue to look at those green days, Will, and actually and do all of those factors, because some of it was about the leading of discharges on a Saturday and Sunday that meant that actually we had a good run into Monday. So, you know, earlier discharges in the day, hitting the 137, having a good run in terms of 0 DTAs and length of stay are a number of things that contribute to a multifactorial picture.
I think we need to move away from views into using the evidence that we've got.
Yep.
So the portal, we're going to get onto it. I know University Hospitals Portsmouth have done quite a lot of work around what's driving their delays. The nationally accepted view is 40% of delays are within the control of the organisation that the delay is taking place in. Now, for low-hanging fruit, that should be the place that we're focusing on. So we are going to get our data locally. We're validating it with the region. So, and we need to be clear at this board. So it's not a view, it's not a feeling in our waters, it's not anecdote. It is what is shown from the data we've got that will drive improved performance. So between now and our next board meeting, we'll have that in place. We'll have agreed it with UHP and RCHT so that we're really clear around the data that we're using with the ambulance service plugged into it, and then we'll be able to bring it back through. We need to do exactly the same for mental health and for community services. Urgent community response, virtual wards. We need an awful lot of metrics around our services to show how we're using them.
Excellent. So
I can.
I'm just conscious of. Is it? Do you need to?
I wanted to address a question Sanjay asked about trajectories and are we clear on what needs to be achieved. From an RCHT perspective, and I know my role here is an NHS provider, but from an RCHT perspective, we have propositioned that that target should be no more than 50 delayed discharge patients, P1, P2 or P3, occupying RCHT beds. Yesterday it was 114. So that there is a figure, a proposition that could be part of that work, and that may not necessarily be agreed by all colleagues. But just to address Rachel's comments, I think I said that from my perspective, the single greatest factor was the number of patients occupying an acute hospital who are waiting for discharge. Just for the avoidance of doubt, I don't disagree that there are other factors, and I certainly didn't say that, but I would still say that the single greatest factor is the number of patients fit for discharge who are occupying acute hospital beds is the single greatest factor impacting on ambulance delays.
Is it quick?
Well, I was eager to elaborate very briefly on the mental health performance, but I can do that at another stage of the meeting, or could do that now.
Come back. I'm really conscious of time, but if I don't want you not to add what you need to do. So, can you do something in 30 seconds, or?
Yes, I can. I'll pick up positive news from adult mental health. The collaboration with service users around our mental health phone line has meant that the access to that, as
peaked at 730 calls a day. There's a professionals line with about 120 calls per day. And what we're seeing is that referrals into adult mental health services are not reaching the pre-pandemic levels. So some very positive news about working with service users, people who've used the service and increasing access. The IAP targets we recognise are generally to do with the service that we've taken on. And we have a plan around the recruitment of staff, but of course there's quite a lead in terms of how those people are trained and can deliver. I could say a little more about people with learning disability commissioned out of the area, but maybe we'll talk about that another time. And the Building Better Services paper that came to ICSs, which is going to be very important that we pay attention
with the
to.
Performance paper.
Sorry.
With respect, that,
Yeah.
that would be great. On the performance paper. Yeah.
So we've heard a lot of reference to needing a single version of the truth, the data flows around system coordination centre, the need to transform the performance reporting and dashboards so that we can inform our action. But what we haven't got is a sort of investment plan in the workforce and skills that we need to do that. I've raised it, I think, quite a number of years that we need to build the capacity to do that work, which will help all of us to do our jobs better as well.
I think that's what Kate's going to take away.
We do have a proposed investment plan. It's how it all comes together into a single version of the truth rather than multiple versions of the truth. So I don't want to spend money when it's going to be wasteful if we're still not going to have a single version of the truth. So again, that's a SEG discussion that we'll be having.
Okay, colleagues, let's move on to finance. Simon, in your hands.
Thank you. Excuse me. Thank you, Chair. I shall give a brief update on finance. I think the first thing to highlight is the work that's been undertaken in the last couple of months, which has been highly constructive, has been to align the reporting of three organisations, which is why the report you see in front of you is fairly high level at this stage. We are in a position to report in more detail next month, including the sort of risk and mitigations, forecasts, etc. for each of our respective organisations at a level that would be helpful for the committee for the board going forward. So I think that's the first thing to highlight. The year-to-date position in the paper brings the surface of 1.9 million deficit reported in CFT. They're still forecasting break-even for the year end, the ICB is overall, and we have a deep dive session with the Directors of Finance and Finance colleagues next Tuesday, just to run through that to find the solution to that position. Currently, we believe we can find the solution to that position, and we'll be sharing the detail when we next bring the paper to the board and F&P and Commissioning Committee. So, but the detail behind the cause of that particular deficit we would also be sharing. It includes things like agency spend. It also includes service areas that we were very familiar with, such as Wheel Vor, that have been taken over by CFT, and we agreed as a system we'd resource. So that there's a mix of things in there that we just need to resolve and clear out, and I think by the time we meet next time all those things would have happened, hence the forecast outturn position remaining at break even across our organisations. And is there anything else to highlight? That the main risks I think we all believe we have, which relate to the national risk, continue to be around cost of living and inflation. So although it was funded to a degree, it's still much greater than was ever anticipated in both planning rounds. So that's still a concern, but we're not reflecting any particular problem at the moment. We've shown areas such as prescribing showing potential pressure within this report, but we still believe we've got offsets for that we can use to deliver a break-even position. And of course, we've talked around the uncertainties around winter and what resource may or may not be available for that. So again, that needs to be reflected in future reporting. And also just to note, this report doesn't include any of the recent demand and capacity funds that have come through, so that would be reflected in future reporting as well. But I've got nothing to add at this stage, but just to underline the fact that we've done the work of integrating our reporting, and I expect to bring a more elaborate report to this next meeting and to Finance Performance Commissioning Committee.
I'll just give the opportunity to Adrian, Margaret, Mary, Steve, yourself, and yourself. Do any of the teams here who are component elements of this feel any reason not to believe that we're on track?
There is something about CIP recovery, isn't there? So we are, as a system, behind.
We're not delivering on CIP.
Yeah.
That's correct.
So do we have a recovery plan for CIP?
We do. We have offsets for the CIP issues at the moment. So that's why that problem, the year-to-date problem, hasn't been reflected in the year.
I'm looking at forecast outturn. So I think it would be really good if we could have a, just to make sure that as a system, we are going to be able to make sure that we can hit the control total, because CIP is quite a big ask this year, isn't it?
It is, yeah. It is.
Could I, sorry?
On that particular point, can you bring back next time some sort of RAG rating then?
Yes, we can, yeah. I would do that overall. So we're looking to do the sort of poor performance, good performance, middle ground position for the overall, but the RAG rating on CIP will be
presented. What we think is going to be for the last half of the year, effectively. So.
Clearly, all NHS providers are experiencing exceptional financial pressures as a result of the delayed discharges. So it is a matter of fact that with 220 or so beds across CFT and RCHT occupied by patients waiting for discharge, there is an agency cost, there is an additional staffing cost. As one small example, RCHT has 18 extra patients on wards through boarding. Some of those things require extra support. From a SWAST perspective, there are significant additional overtime agency and other expenditures that directly result from this. So I think it would be important for integrated care board members to be aware of that position. If that level of delayed discharges deteriorates, then we will directly see additional cost expenditure in provider organisations. And part of my desire to see transparency on the Better Care Fund and the S256 funding and other things is they are significant investments, and we do rightly expect that they will very rapidly translate into reduced delayed discharges, which will have a direct impact, as Simon knows, on reducing expenditure in the provider organisation. So there is a challenging environment, and I think it'd be really important for us, Simon, as we've already touched on, to see, I would say month by month, the BCF reporting, the 256 and other reporting alongside this, because that gives us a broader picture of the financial position.
Yeah, I was just going to add, Steve, that what has been helpful and partly will offset some of the things you've highlighted, and this is consistent throughout the South West and nationally, is whilst we're not pushing through the levels, for example, of elective activity that we'd like, the issues, the cost impact of that is actually organisations in some areas are spending less. So it provides an ability to offset some of the pressures that we're seeing elsewhere. It's not what we want to see, but it is what is happening.
So just bear with me. So, Tom, was it yourself?
Yeah. I suppose I just want to be aware that with an impending pay award, we've got agency costs that are extremely high. We've got rising costs of actual operation. I'm not quite sure how we can end up in how we can be still projecting a break-even position. I just don't quite understand it. Maybe I'm being dense.
It is partly the uncertainties that you're describing, which you describe very eloquently, have not been translated or communicated through NHSEI yet because of all the various national changes that are going on. So the expectation at the moment is where there are significant issues like that, they may be resourced, but we're not clear because of the national politics.
So we wait just a short window for the national politics to play out.
Yeah, so I think
invite Simon to come back, particularly next month.
Yeah, so I think we're hoping, everyone's hoping we will be a little clearer next month.
Okay, so I'm going to invite, because now I'm really going to try and wrap up in terms of time, Kate and Rachel, and then we'll move on.
So I think it'd be really helpful if we could do a piece of work outside the boardroom to work out what the marginal costs are associated with people being delayed in beds, because we're not on counting and coding contracts, we're on block contracts, and the beds are already staffed. So we just need to work out what exactly it is that's playing through into our financial position, what is around CIP, what's around escalated costs because of a hard winter and fuel and inflation, so that we understand the numbers that are in front of us. I'm fairly au fait with NHS finances, and I don't understand the numbers that are in front of us. So I think it would be really good if we could have a piece of work with Carl, Lady and Simon to bring it back so that what's in front of us we can sign up to as our statement of fact and truth. And I would like to get into that marginal cost stuff because that's where the agency costs kick in.
Final word on this, Rachel?
Just as a kind of principle, really, Chair, I think it's really important when we take the suite of these that we look at them as a balanced scorecard, because the trade-offs between, potentially underactivity from the financial impact, but what that means from an operational and outcome and quality impact, we must see that in the round. And equally with the workforce challenge that Steve mentioned, actually our vacancies and actually our approach to recruitment to offset that agency and our sustainable workforce is really important. I think as a board it would really important for us to hold that balanced scorecard view on these things, please.
Let's move on, please. Thank you. So, thank you, Simon. We'll see you through the committees and see you next time. So, I'm just going to jump for a second to the next agenda item because I think the next one can buy us quite a bit of time. We've got only 50 minutes left to go. Because I do like to arrive and depart on time, everyone.
We know.
Sort of P&O part of me again. So here we go. So in terms of confirmation of the board agenda and forward plan, can I just be clear? I think what we've agreed is that next month the main papers are intermediate care, strategic priorities and winter plan.
Because we absolutely concertinaed Adrian around mental health and learning disabilities, there is a new learning disability policy document that's come out, and we are being challenged really hard around repatriating out of area people with a learning disability. I think it would be good if we could have a deep dive into our learning disability services end to end. So if we could maybe have 20 minutes on the agenda for that, I think it would be really helpful.
I'm really happy for us to have a broader agenda than here.
Yeah.
But happy to add that, Trudy, if you want. But these are what I would then sort of say. These are the strategic papers and the things that we need to really have here. So are you comfortable that in 4 weeks' time we'll have an intermediate care paper, not an update, but an intermediate care strategy? Because if you're not, it takes us on to our transforming care for Cornwall discussion in a second, which is why I've jumped one.
So I don't think we'll have a strategy, but we do need to have a work in progress, because intermediate care is so important for this winter. And if we haven't got a plan for it by October, then we are going to fail to be able to support people in their own homes. So I think we do need to bring it, even though it's going to be difficult. I think we need to bring something. Helen.
Helen is the lead. So can we just change that to Helen, please? So Helen, you're clear on what you're bringing for intermediate care? Or you will be.
We will be.
You will be. And who's leading on the winter plan for the group? Is that still Rachel, or is that?
I don't think we fully confirmed the number of components on that, but what we need to do is the component parts of the control centre and the EPR. So if we can take that aside, Chair, and bring that back.
So to be fair to me, whatever you do, I just want one owner from here who can. So are you going to take away? Whoever comes back and leads on it, would you take away from today, making sure we have an owner?
Yeah, we'll do.
Thank you very much. And on the strategic priorities, we've got you down, Kate.
What, sorry?
Strategic priorities, is that still?
So that's transforming care, isn't it?
It can be whatever you like.
Yeah, that's fine.
Okay, so that's done. Okay, so let's move on then to the next paper. Unless there's anybody else wanted. Yes, Trudy?
I think we said we'd bring something back on BCF to October as well.
That was the November one.
No, I think we've brought it forward to October, and grants may come back to November.
So it's 2 items.
Yes.
Done. Everybody happy with that?
Yeah, and I'd like to link BCF with intermediate care, so the two that come together as a.
Very good. That's why we're doing this kind of thing. It's just
it almost looks like we planned it.
Are we confirming the LD and A paper? Perfect.
Neil wanted to come in.
It might be a question for Trudy, but you mentioned the importance of, say, committee chairs knowing what's coming up on the forward work plan. It's jumping about a bit. Is it possible that we could have a copy of the updated forward work plan so that we're quite certain
so one of the things, Trudy,
what we
I know
need
you
to
take
link
a while
in
to
with?
do because of time and everything, but as soon as we come out of here, if we could get the forward plan out, park the minutes for a sec, get this out, then I think that would help everyone know what's coming.
And the expectation is we will try and get these things through committees before they come up
Correct.
to the board.
Yep.
That
Yep.
will be the
Yep.
default
Yep.
position.
And I'll just say again, in case I forget to say it at the start, papers now will come with a heading that says, have they been through SEG, have they been through the committees, if so, have they gone through sovereign boards, and if not, at least we're cited when we read the papers where they've gone. Okay? So, we have 10 minutes, because we have 12 minutes left. I want to make sure there's any questions from our public. Can we have the Transforming Care for Cornwall, what you would like out of this, really?
Okay, so I'd just like us to think about where we are in terms of delivering the priorities that we set ourselves. So as an executive, we identified the priorities that we thought were going to be the most important for us. And as I say, we looked like we were, I used a different word from clairvoyant, visionaries, because the things that we need to deal with are the things that are now starting to tax us in terms of our day-to-day delivery. We set up our delivery in a matrix way, and we are not delivering to task or time across the range of projects that we've got up and running. And that isn't particularly because people don't think they're important, it's because everybody is very stretched in what they're doing. We've had a review from PRISM around how we have orientated our governance around transforming care for Cornwall, and we also have a PwC view, both of which concur. We need to make it a lot tighter. And we also need to get products out of people that say what they're going to do and how they're going to do it. Fundamental to that is that we need to restate that we think that the priorities we've set ourselves in the light of the discussions that we've just had are the priorities we need to deliver. That's the first ask I've got of the board. And the second is that we seek to streamline both the information that underpins the programmes that we've got and the single way of working through an aligned PMO. That means that the messaging to our people is that these are the programmes of work that we as a leadership community for Cornwall and the Isles of Scilly are expecting all of our teams to get behind, so that we can be in a position to make some rapid transformation in access and outcome of care for people in Cornwall.
Okay. Any questions? So if we've got 6 priority programme boards that we've inherited, I'm just going to ask the question. I'm not saying this is the answer, by the way. So if we've got Steve, for example, as urgent emergency care, at what point in the journey do you consider that actually should be morphed into a new flow and discharge priority group, programme board? Who is the SRO? Who's actually underneath that? So, for example, with Will here, if that was the case, who would you consider, and if you were the SRO or whatever, who would be considered to be on that? So we've actually got a senior cohort of people given the mandate by this group to actually go and do under your auspices what it takes. How measure everyone's expectations for what we might see back from this same next month?
So we have 2 legacy boards, which are the Urgent and Emergency Care Board, which used to be a compulsory, you need to have it in your governance arrangements, and the Planned Care Board. My personal view, and we need to test this through SEG, I think, is that the Urgent and Emergency Care Board is driving the flow programme. Now, that doesn't mean to say that Steve has to be the SRO for the flow programme, but that we could identify an SRO. It reports through at the Urgent and Emergency Care Board, because that's where we will see the impact of flow, and that we account for it via SEG into our committees. The recovery of referral to treatment, elective care, the Planned Care Board is doing that already. So we just align the boards underneath the portfolio programmes of work so that we're very clear about what sits where, with clear SRO ownership. And I think we need to revisit what an SRO for a portfolio programme means, and that we then have a team working with the SRO to deliver said programme. So a bit of collapsing and a lot of clarity.
It's for you as execs to propose. I guess the challenge I just wanted to throw out is it's a bit like my challenge on how many strategy documents we've got, kind of thing. Now might be the moment to sort of say, even if it's collapsing, are we all clear on who is the group of people on that top priority, and are they clear what mandate they've got from this group? And however you choose to pull that together, I don't mind. But to then have somebody else sitting over here, another group, thinking they've got the mandate, it just feels like one too many mandates to me. Can we try and keep this simple, is my request. and whatever you agree and come back with, I think that's for me what I was hoping you would come back with next time.
Yeah, absolutely.
Is the clarity of what you as a group of executives, through whatever channels of organisations you've got, that would come back here, not just the base principles, but do nail the scope, the SRO, whatever it is, their mandate, what it is, and who's on the teams, such that everyone outside this room can be clear as well.
So I think that bit's really easy to do, actually. It's the bit underneath, it's around the intention to do something with that structure. So how will we have a single way of working through programme management? Because I understand one of the reasons why we haven't got PIDs from people is a disagreement around a mandate comes before a PID or a PID before a mandate. I really don't care. I just want to know what you're going to do and how you're going to do it and what you need to do it. Yeah. So it just has to be a simple process that every organisation that's involved is committed to. That if you are a project director for a project that links into a programme, you know that it's your piece of work to do, and every organisation supports you, not just the bit that's in your organisation. It might span organisations. I think we need to be really clear about that, and we need to be clear about the leadership of a single PMO function that may be provided in different places. Margaret's just whispered in my ear, through a service level agreement if we need to do that, but it's really clear that we've got one endeavour.
Exactly. So I think all I wanted to get out of this was collective agreement that we would empower Kate, Steve, Debbie, whoever it is within that group, to go away and work out such that next time we come back there is clarity. I think that's the point. Let's have clarity. Everybody happy with that?
Yeah.
Martin?
Yeah, just a very slight build. I know you're talking about delivery structures, but we have been talking with Carolyn about strategic objectives, strategic risks, and principal risks that we can reflect in our board assurance framework with mitigation. So that piece of work, I think, also has to flow out of some of the work you've just been talking about, John.
So I think that's normal programme methodology, isn't it? I mean, I know we haven't been doing normal programme methodology, but the risks and the mitigations have to be part of the programme plan, and that's what I'd like to bring back here. People have been doing this since January. We're now in September, so my challenge to colleagues would be, can we see your paperwork?
Very good. Wholeheartedly agree. Colleagues, let's move on. It's 5-2.
Carolyn's got her hands up.
Very quick. Can I just ask, when we're talking about this outside of here, that we just remember the one vision? You need to think about how we bring that into the round.
So I think in the scale of 3 hours, to have left 5 minutes when I planned, or we planned 10, I'll note to self, I'll go away, self-appraisal, that wasted 5 minutes somewhere in the journey. Any questions from the public, though? On screen or here? So you are the public. You're representing over 500,000 people.
Massive responsibility.
Could you speak up, please? Could you come to one of the microphones, please?
Thank you. It's an observation, really. It's been a privilege just to sit and listen to everything that goes on. The operational side of it, which I don't understand, I can see it's going on. And your hope to simplify that so that I can understand it and I can benefit from it. And so I really appreciate, thank you for all the work that's going on behind the scene that we don't know about. But I was particularly interested also in...
Sorry, I can't hear you.
Sorry, I was particularly interested in your focus on mental health of the workforce, which is essential. Good workforce means that I benefit from that. And also, one thing I don't like is the word discharge, because if I'm in a hospital, I don't want to be discharged and just I want that to flow, as you say. So it's a case of being taken care of, right through the system and not having any gaps in that. I do see the gaps, I do see the problems, and I think that where those gaps exist, then there is a risk of people getting ill again and coming back into your system. So it's an economy really to have that smoothly running through. But just thank you very much. Thank you.
Thank you.
Thank you. On the screen, is there anybody who would like to ask a question? No hands. Well, thank you very much. So just to pause then and thank everyone for a long journey today. Thank you for bearing with us in terms of teas, coffees and breaks. So the idea now is it's, gosh, we've got a whole 2 minutes to spare if we wanted to. We've got some colleagues, Andy, coming in a second, I hope. For those,
I hope, but otherwise Joan will definitely circulate.
Okay. For those who would like to pause and meet those ICA reps who are here, do so. If not, you know what I'm like. We're going to start part 2 on time. I think that is 1:45. So we will start at 1:45. See you then. Thank you very much, everyone. Have a good day.
Thank you.